Good morning, everyone. Indeed, it's a delight to have our global friends from various parts of the world contributing to the AORA Global. And the entire proceedings will be live on Anaesthesia TV. We have Dr. Sameer Narose, the immediate past president of the American Society of Regional Anesthesia, sharing his thoughts on perioperative management of patient receiving cannabinoids. This is followed by a talk by Dr. Ashoka Balakrishnan, the current treasurer of the Asian Oceanic Society of Regional Anesthesia and Pain Medicine from Singapore. He's going to speak on structuring training in regional anesthesia to improve patient outcomes. This would be followed by the leadership of European Society of Regional Anesthesia, Dr. Clara Lobo, who is currently working in Abu Dhabi, who will be speaking on how to make your block work. This would be followed by Dr. Bo Gotashu from Denmark, a regional enthusiast, who is going to speak on safety rather than mastery, followed by the talk on equity and diversity by Dr. Elena Moka, the Secretary General of the European Society of Regional Anesthesia and Pain Medicine from Greece. This will be followed by a talk on Caudal anesthesia for day care by Dr. Mohammed Fatil from Shahridan Fatil from Malaysia, who was a member of the board of directors of Asian Oceanic Society of Regional Anesthesia and Pain Medicine. This would be again followed by the second talk by Dr. Clara Lobo on regional anesthesia in anticoagulated patient. And to end the session, we have a very interesting talk on Danish model in regional anesthesia by Dr. Bo Gotashu from Denmark. With this introductions, we go on to the first talk by Dr. Sameer Narose, the immediate past president of the American Society of Regional Anesthesia. I extremely, on behalf of the entire team of Academy of Regional Anesthesia of India, convey our sincere thanks to all these global leaders for sharing their thoughts and being a part of the 13th Annual National Conference of Academy of Regional Anesthesia virtually. Over to Dr. Sameer Narose.
Member and the board for the American Intervention Headache Society and the American Board of Headache Medicine. I get loyalties for some books. So why you are interested in this topic? A couple of years ago, we did this survey among the pain physicians in North America, and we find there is a big mismatch between the pain physicians' favorable attitude to recommend cannabis to their patients and their willingness to do so. And we identified two main factors for this. Number one, they fear getting in trouble with the authorities. Number two, lack of education and knowledge about cannabis and its potential medical applications. So marijuana in USA, or cannabis, it's the most commonly used illicit drug. It's category 1 federally, which means that there is no clinical use or medical use of it. According to the National Survey on Drug and News and Health in 2017, past month, there are about 26 million users. 4 million, they met the classification or the diagnostic criteria for cannabis use disorder. Globally, the cannabis is ranked up high among the other illicit drugs. So according to the Global Commission on Drug Policy, the report in 2019, there are significant potential harm to the consumer as well as to the community. So cannabis ranked higher compared to benzodiazepines, methadones, LSD and hallucinogenics, and buprenorphine. Why it's more relevant recently? Because we are seeing different potent products now in the market. This is even an old study, almost 10 years ago, and they found that between 1995 to 2014, the THC potency tripled in those 20 years. You can see here it started with 4% THC, it's up to 12%. Again, this is about 20 years ago. Also, the ratio between THC and CBD increased dramatically. Now, actually, you can manufacture a very concentrated THC product, up to even 90% of THC, which is very scary. CBD, it's over the counter in the USA as long as it contains less than 0.3% THC. We see now CBD infused in everywhere in our daily life. CBD infused burger, CBD infused wine and drinks, CBD infused coffee, tea, and even CBD infused yoga pants to increase your, enhance your training. So let's start about the pharmacology of the cannabis plant and the cannabinoids in general. The cannabis plant contains many molecules, about 120 cannabinoids. And there are other chemicals, non-cannabinoid chemicals in varying concentrations. Some of them we know, some of them we don't know. That's why when we read any study reporting on the use of cannabis plant, we're not really sure exactly what's in this plant, what are the molecules in it. That's why we have variable results from different studies. We really need to study specific molecule that's regulated, and we know exactly the dose, the concentration, and the route of use. So we'll talk now about the endocannabinoid system. Now in the USA, most of the medical schools now are adding the endocannabinoid system to the pharmacology curriculum in medical school. So it contains 4 things. First, the endocannabinoids, which mean that they are manufactured endogenously in the body. The 2 most common ones that we know about that are well studied are the anandamide and the 2-AG. And then they have enzymes to synthesize them and enzymes to metabolize them. And then the cannabinoid receptors. The 2 main ones are cannabinoid receptor type 1 and cannabinoid receptor type 2. And then the proteins that's transporting them across the cell membrane. So these are what constitutes the endocannabinoid system. Generally speaking, cannabinoid receptor type 1 are more centrally located, the CNS and the spinal cord, while the cannabinoid receptor type 2 are more peripherally located, almost in every organ, the lymphatics, and even in the skin. However, they are also present in the spinal cord, especially in the dorsal root ganglion, and more recently, they were found to be in the brain, especially in the microglia. The CB1 receptors are focused or concentrated in the CNS, especially in the brain, as well as the spinal cord. And actually, the cannabinoid receptors are one of the most abundant receptors in the CNS and in the human body in general. In the CNS, they are responsible for, they are concentrated or expressed in high intensity in the areas that are responsible for movement, sensations, memory, judgment, and coordination, as well as vision. Both type 1 and type 2 receptors, they work in harmony. When they are active, they can modulate the pain, the neurodegenerative disorders. When they are inactive, can lead to obesity, addiction. Again, they work in harmony with the CB type 2 receptors. And again, if those receptors are active, they are very involved in modulating inflammation and pain. When active, they can have a significant role in cancer and renal fibrosis. So this slide and the next one will explain the anti-nociception mechanisms of action of cannabinoid-based medications. What's relevant to us as anesthesiologists and pain physicians. The cannabinoid type 1 and type 2 receptors, they are G protein coupled receptors. They are, they have similar amino acid sequences. They are transmembrane. The N terminus is the hydrophilic terminal. It's outside or extracellular, while the C terminus is the lipophilic one, is inside the cell. Once the ligand attaches to its specific part of the receptor complex, it activates the receptor complex and leads to coupling and modulation of the G protein, and this will start the intracellular signaling. Then on chronic stimulation, long-term stimulation, there start to be phosphorylation of the receptors attached with beta-arrestin, and this will lead to desensitization, endocytosis, recycling, and downregulation of the receptors. And we'll talk later why this is important to us. I think this is the most important slide to understand in general the pharmacology of the cannabinoid molecules and how they can interact with different receptors in many different ways, leading to unpredicted response. So this will affect the interpretation of the clinical studies that we have. Because again, most of the clinical studies we have, it's related to utilizing plant cannabis, which has more than 120 cannabinoids. Some of them we don't even know the potential actions and implications. In general, the endocannabinoids are sensitized on demand, which means that acute trauma, surgery, stress, acute inflammation, there is lots of action potential to the postsynaptic neuron and leads to stimulating the synthesis of those endogenous cannabinoid from the phospholipids, maybe from the phospholipids in the cell membranes. So with the sensitizing enzymes, we'll have here, for example, the 2-AG, one of the endogenous cannabinoid. It's sensitized in the postsynaptic neuron. So it has to go retrograde to interact with the cannabinoid receptors in the presynaptic cell membrane. So when the TAG attached to its activating part from the cannabinoid receptor complex, it activates the system, and this leads to modulation of the G protein and starting the intracellular signals. For an active or agonist ligand, once it activates the system, it leads to decrease in the cyclic AMP because it decreases the adenylate cyclase enzyme and leads to inhibition of the voltage-gated activated calcium channel. Inhibition of calcium channel while enhancing the potassium channel. This leads to decrease in the release of the neurotransmitter, the excitatory neurotransmitter. So leads to decreased release of those excitatory neurotransmitters, and this accordingly will lead to analgesia. There is different pathway, the MAPK pathway, but this more related to cell proliferation and has impact in the cancer thing, but not really in the analgesic one. Then the 2-AG is metabolized in the presynaptic part, and then it degraded to arachidonic acid and glycosol. So this is in general how the endogenous cannabinoids are sensitized on demand and how they are affecting, modulating the cannabinoid receptor 1 and 2, leading to inhibition of the neurotransmitter release, and then leads to analgesia, and then they will be metabolized in the presynaptic neuron. We'll look at the illustration on the left, and we'll see the interaction or the interplay between different cannabinoids, whether endogenous or exogenous from outside. So the blue one is the one of the endogenous cannabinoid, the 2-AG. So this is a typical ligand, typical agonist of the CB1 and CB2. So it attached to specific parts on the protein, on receptor protein complex, modulating the G proteins, the 3 units, and this leads to the intracellular signals. This is the normal or the typical agonist for the receptors. If we have exogenous cannabinoid, and this only one of them, PEPCAN12, imagine we have 100 of those exogenous cannabinoid with the cannabis plant if it's smoked. It can have different, each molecule can have different mechanism of actions on different cannabinoid receptors. So for example, this PEPCAN12 will have negative allosteric modulators, which mean that it's not a typical agonist or antagonist. It's attached to a different part of the receptor complex, and accordingly, it can modulate the agonist, modulate the typical ligand, modulate the endogenous cannabinoid. So in this case, it's negatively modulating this ligand, which means that it attaches to a specific part, accordingly, and inhibit the effect of the typical ligand, typical agonist, and this leads to blockage of its intracellular mechanism, so decreased signaling. On another receptor, on the CB2 cannabinoid type 2, actually it can act as a positive modulation. So it enhances the activity of the typical agonist or ligand, leads to augmenting of the intracellular mechanism. So the effect of exogenous cannabinoid depends on the percentage of the concentration of different cannabinoid receptors, and actually the presence of the endogenous cannabinoid. High tone increased the endogenous cannabinoid or depletion of the endogenous cannabinoid, because in the absence of the typical ligand, they will have different mode of action. So this complicated interplay between the many cannabinoid we have and the different or differential effect on different receptors can be very confusing. And this leads to different clinical effects. So interpreting the data from clinical studies will be very difficult, especially if we have a meta-analysis and we're pooling the results from different studies, studying different dispensary product with different route of use and with different endocannabinoid tone. So the endocannabinoids, the two most common studies are the 2-AG and the anandamide. The 2-AG is a full agonist of both type 1 and type 2 receptors. The anandamide is partial agonist of type 1 receptors and actually agonist at the transient receptor potential vanilloid channel, which is the capsaicin receptors. It's metabolized. Here, the anandamide is metabolized by the FAAH, which is the fatty acid amide hydrolase. This is important because we can modulate or inhibit this enzyme, and accordingly, we can enhance the concentration of the endogenous anandamide, and this leads to more analgesia. And this was very well illustrated in this case report that showed this patient has does not feel pain. She had natural birth without feeling pain. Why? Because there is high level of anandamide. So this led to pain insensitivity. Why? Because there is microdeletion in the FAH pseudo gene. So there is abnormal FAH enzyme, so she cannot metabolize her endogenous anandamide, leading to high tone of the endogenous cannabinoids, and this leads to pain insensitivity. Phytocannabinoids are the cannabinoids in the plants. Hundreds of them. The most well-studied one are the THC and the CBD. THC is responsible for the classic, we call it the classic cannabinoid, the tetrad, which is hypothermia, hypolocomotion, catalepsy, and analgesia. THC is the most characterized or most active psychoactive cannabinoid in the plant. It's partial agonist for both type 1 and type 2, but more on the type 1, which is centrally located. That's why it's more on the CNS. So it causes more the analgesia, central analgesia, dissociative analgesia. However, it can have a spectrum of effects, mixed agonist-antagonist profile, depending on, like what we showed in the last slide, the cell type, what is the concentration of type 1 and type 2 receptors, the receptor expression, because in acute stress state or acute trauma, there is more expression of those receptors and more release or sensitive of the endogenous cannabinoid. So it depends on the endocannabinoid tone. If the endocannabinoid tone is high, lots of endocannabinoids occupying the receptor, then the THC can interfere with the function of the endogenous cannabinoid. Presence of other full agonists, whether endogenous or exogenous, because they can displace them or they can have mixed interactions or interplay between them. THC has a paradoxical effect, which means in high concentration, high dose, or long-term exposure can work as an antagonist of the type 1 receptor, can lead to down-regulation of type 1 receptors, because once they are overstimulated long-term, we can lead to desensitizing dysregulation of the cannabinoid type 1 receptor, and this leads to increased effects. Also, it works on other receptors, especially the G protein receptor 55, which is the main one of the main mechanisms of action of CBD. That's why some consider this cannabinoid receptor type 3. Also, it works on some opioid receptors, serotonin, glycine receptors. So this slide summarizes in general the paradoxical effects. For example, low THC will lead to anxiolysis. High THC will cause panic attack, psychosis, especially paranoid psychosis. Low THC, vasodilator, coronary vasodilator, increased blood flow. While high THC can cause massive vasoconstriction, hypertension, coronary vasospasm, myocardial ischemia, as well as cerebral vasoconstriction syndrome. And this might be more prevalent in pregnant women, high users of or heavy users of cannabis. At a low dose, it's antiemetic. Actually, we have one or two synthetic THC that's FDA approved for severe emesis with chemotherapy. On the other hand, high potent THC can lead to hyperemesis syndrome. In pain, this is well known, low concentration will lead to analgesia. High concentration, long-term use can lead to hyperalgesia. CBD is the less psychoactive one. It really works more as an anti-inflammatory or antioxidant one. It's anti-epileptic. There is one now that's FDA approved for 2 forms of epilepsy, neurodevelopmental epilepsy. Its main mechanism of action, it modifies the negative effect of THC. That's why we use them in combination. So it will prevent the psychoactive effects or the undesired psychoactive effect of THC. How it does this? Because it's a negative allosteric modulator of the type 1 cannabinoid receptors. Also, it inhibits the cellular reuptake of anandamide. So it increases the level of anandamide, increasing the endocannabinoid tone. As I said before, it's an agonist of the G protein receptor 55, and its main anti-inflammatory and immunosuppressive effect is due to modulation of adenosine type 1 receptors. So we talked about the endogenous cannabinoid, the phytocannabinoid, which is the plant one, now the pharmaceutical one. In the States, we have two FDA-approved, nabilone and dronabinol, for nausea and vomiting with chemotherapy and for anorexia and weight loss in HIV disease. Then recently, a few years ago, FDA-approved Epidiolex, which is the cannabidiol, the CBD, for two neurodevelopmental types of epilepsy in the pediatric population. Then Sativex, its name in the USA is nabiximols. It's still investigation in the USA. However, it's approved in too many countries abroad. The good thing, the advantage about it, that it comes as a more oral mucosal spray, so there is no vaping or inhalation, and also it has a ratio 1-to-1 of THC and CBD. So the CBD will prevent the negative psychotropic effects of THC. Cannabinoid metabolism. It has extensive first-pass metabolism in the liver, phase 1 and phase 2. One of the products of one of the metabolites of THC is more potent and have a longer half-life, which is the 11-hydroxy-THC. Same with CBD, one of the metabolites is active, has long half-life. That's why we have very poor correlation between the urine or plasma concentration and the degree of intoxication. Because even with one incident of exposure to THC, you can have the metabolites in the urine and the plasma for weeks after. The THC itself can last for a long period of time, and the metabolite is even longer. So this we call the triphasic response. It's very lipid soluble, so it reaches the high blood concentration and quickly crosses the blood-brain barrier after even after 1 or 2 minutes from inhalation, crosses the blood-brain barrier and then distributed to the high perfusion tissues first and then the low perfusion tissues. And then it got sequestrated in the fat. And then days later, it starts to get released from fat. And then it can be in the blood for a long period of time. That's why measuring the concentration in the plasma or urine won't be a good indication about acute intoxication. It can tell you that the patient had exposure to this cannabis sometime in the past few weeks. Interactions, this is important, especially when we talk about perioperative management and interactions with different anesthetic. The main drug interactions are actually pharmacodynamic interactions when it's combined with other CNS depressant or sedatives, like any CNS depressant, alcohol, opioids, benzodiazepines, antihistamines. Also, when it comes to tachycardia, anything that stimulates the sympathetic system, tricycle antidepressant or any stimulant or sympathomimetic can increase the risk of arrhythmias and tachycardias. The THC, most of the cannabinoids are metabolized by the cytochrome P450 enzymes. The THC is mainly the 3A4 and the 2C9. The CBD actually is 2C19 and also still 3A4, which is metabolizing almost 50% of our drugs. That's why theoretically it has a huge list of drug-drug interactions. However, clinically, I would say the pharmacodynamic interactions are more important than the pharmacokinetic ones. It has some interference with muscle relaxant, with anesthetic, special propofol, blood thinners, but it's not really clinically very relevant. So any drug that inhibit or induce those enzymes will lead to increase or decrease the THC and the CBD blood levels. Perioperative management. Recently in January, we released the ASRA Pain Medicine Consensus Guidelines on the management of patients before, during, and after surgery if they are exposed to cannabis and cannabinoid-based medications. I just want to make sure that it's not every patient who uses cannabis will get in trouble during surgery. Many cannabis users are using it safely and will have a smooth perioperative course. However, some may encounter adverse events, and we identified 3 subgroups of those patients. So this was a consensus panel, expert panel, 12 members panel, anesthesiologists, pain physicians, patient advocates, psychiatrists, and we came up with 21 recommendations and we reached 100 consensus. This is a summary of all the recommendations. So why we needed the guidelines? Because cannabis is the most commonly used illicit drug. 10% of Americans used cannabis in the last month in the 2017 survey. Legalization and decriminalization of cannabis over the last decade led to increased use of cannabis and commercialization in the USA and abroad. More importantly, recently, we start to see high potent THC products in the market. So earlier studies that studied the low potency might not be relevant to the patient experience at this time using the high concentrated THC. THC works, as said, mainly on the cannabinoid receptor type 1, and this leads to activation of the sympathetic nervous system. Accordingly, this will lead in long term, will lead to cardiomyopathy, myocardial infarction, arrhythmias, cerebrovascular disease. While CB2 receptors might have protective effect, actually. So this is a summary of the available literature. There is increased risk of post-operative MRI 1.88 in patients with active cannabis use disorder. The increased risk of having a myocardial infarction is more in the first hour. 4.5 increased odds of having MRI in the first hour. And then the risk decreased dramatically. After 2 hours, it normalizes. Increased risk of post-op hypotension, increased risk of stroke and TIAs, DVT and coronary and CVA. Because of the effects on the blood vessel wall, the intima, and vasoconstriction, inflammation, there is now a well-known syndrome called cannabis vasculitis or arthritis. So in any young patient, less than 50 years, it should be in the differential diagnosis of patient presenting with peripheral vascular disease, cannabis-induced vasculitis or arthritis. However, I want to be fair. When we reviewed the literature, there are some conflicting reports. So some reports showed association between legalization of cannabis in some of the states where there is legalization of cannabis. This was associated with increase in hospitalization and ER visit for acute MI. Also, the other observation studies showed temporal relationship between cannabis use and arrhythmias, especially AFib, tachycardia, and acute MI. This is in young patients because of increased sympathetic tone, even young patients without risk factors or history of ischemic heart disease. On the other hand, in the cardio study, they followed individuals more than 25 years. 84% reported use of cannabis use. Actually, the cumulative lifetime and recent cannabis use did not show any association with increased cardiovascular disease. I put this because this is one of the most recent studies. It's a cross-sectional study, a survey of more than 33,000 respondents. And it showed that frequent cannabis users, as defined, using it more than once a week or 4 times in the last month, they have 2.3 odds of reporting heart attack. Less frequent users, they have only 1.5 odds of MI compared with non-users. It was statistically significant for smoking, but not for the edibles. So the takeaway message is recent cannabis use was associated with increased odds of self-reported myocardial infarction in adults between 18 and 44 years old, which is the surveyed population. However, we have to carefully interpret the literature because most of it are observational, cross-section studies, or retrospective, short-term, lack of exposure determination. There's definitely some recall bias. There is no standardization. We don't know what product. Not all the studies are reporting the route of administration. And definitely there are some co-founded factors that will does not generalize the findings, especially the co-founding with tobacco use. Most of the people who are smoking cannabis might be tobacco smoking, and this also has significant cardiovascular morbidity. So those are the three subgroups that we identified. Acute intoxication, patient cannot make a decision, cannot sign informed consent, so we need to postpone the elective surgery, and this was grade A. Acute cannabis smoking, we need to delay the surgery at least 2 hours because of increased risk of myocardial infarction and arrhythmias. And this was grade C because there is no well-designed studies. Frequent cannabis user or patient presenting with cannabis use disorder, those are the ones that may have drug interaction, may require higher doses of propofol. They will have a paradoxical effect and more post-operative pain. They might experience cannabis withdrawal symptoms in the recovery room, and the major presentation of cannabis withdrawal symptoms is pain. That's why it's difficult to control the pain in the post-operative period. So those four recommendations reached grade A level. We used the United States Preventive Service Task Force methodology. A stronger than B, C, D. E is indifferent that we cannot come up with a recommendation either way. So grade A, universal screening of cannabinoid by asking the patients a questionnaire about what type they used, the amount they used, the frequency, the last time they used, the route of administration, and is it recreational or medicinal. If they have an acute intoxication, mental status changes, we postpone surgery, and this is grade A. All the patient need to be counseled regarding the potential and a negative effect on the post-operative pain control and pregnant patients. So these are grade A. Grade B, cannabis used during pregnancy and the immediate postpartum period should be discouraged because of the effects on the neurodevelopmental of the newborns. Other were not strong evidence because of lack of clinical studies, which is mainly we delay surgery by at least 2 hours after acute smoking of cannabis. Edibles take a long time to have an effect. So this is only for smoking in the first 2 hours because of increased risk of MI and tachyarrhythmias. We did not reach a consensus about tapering of cannabinoid in the perioperative period. But recreation cannabis, we strongly encourage to stop it a couple of weeks, especially smoking. We deal it like any smoking. But medicinal cannabis, the patient are on those for good reasons. They need to counsel their treating physician. Misinterpretation. We recommend universal screening by asking those questions, and this grade A. However, we recommend it against universal toxicology because people misinterpret and they thought that we are recommending universal toxicology screening for every patient presenting to the OR if they said they are using cannabis. We recommend screening by those 5 or 6 questions: the type, recreational or medicinal, the time of last use, the amount, the frequency of use, and the route of administration. Actually, universal toxicology screening is not indicated, and it reached grade D, which is we recommend against it. Future research. We really need randomized controlled trials. However, we know that it's very difficult to do it with the current environment surrounding that cannabis is still class 1. So maybe if we have synthetic products, if we have a standardized product, this would be the best way to ensure a cause and effect relationship. Meta-analyses, we have lots of meta-analyses and systematic reviews. The issue is that we cannot pool results from two heterogeneous samples. This leads to difficult to interpret the results. So I think at least currently the best way to study cannabis and cannabinoids will be population-based studies, program-based protocols, large data or registries, and pragmatic trials. It's very common in the cannabis literature to see cross-sectional studies, which are like surveying people, case controls, case reports. They are good to identify the long-term effect of cannabis use, the side effects, the complications, the paradoxical effects. So I will end by this slide that the current evidence-based practice is based on the best scientific evidence, which is not really rigorous. We have really good basic science about cannabis and cannabinoid, but this does not translate it to clinical evidence yet. Clinical experience, which is limited, patient values, all those participate in our evidence-based practice. The old traditional pyramids for the grading of evidence, we used to say systematic reviews and meta-analysis in the top of the pyramid, randomized controlled trials. I think we should remove systematic reviews, at least when we study cannabis, because of the poor quality of the studies that's got pulled into this systematic reviews and meta-analysis. Unless you pre-register the protocol and you know the primary question, sometimes you run the meta-analysis bias, you change your primary question because you want to fit some narrative. Especially cannabis now is very politicized and commercialized in the USA. That's why I believe RCT trials still should be on the top of the pyramid. This is very rigorous statistics. Might be difficult to do it with the plants and the dispensary product, but with any new cannabinoid molecules, this should be the way to go from here on. Once we have good quality RCT trials and observational trial population studies, then we should be able to pull the data from good quality studies so we can have good systematic reviews and meta-analyses that we trust their findings. So clinical evidence, making your same mistake with increasing confidence for an impressive number of years, while evidence-based medicine is repeating others' mistakes instead of yours just because they published the results. Thank you very much. I hope you learned something from this talk. I'll be happy to address questions either on Twitter or the email, which is my last name and first name @gmail.com. I'm from Northeast Ohio, a small city called Akron, which is the birthplace for the best two basketball players in the world, LeBron James and Steph Curry. Thank you very much for having me.
Hello, thank you AORA Global for this opportunity. Today I'm going to discuss on structuring training in regional anesthesia to improve patient outcomes. This would be from the lenses as an anesthesiologist who's practicing and an educator and somebody who also looks at quality of regional anesthesia. So training in RA is generally focused on about how the residency or the 3 to 5 years is about, but I would bring you to more than that, where we should look at like how we do in this conference on paramedic or team training, and then also about the trainers and how they continue to be professionally competent. So today's focus, if somebody had to give a discourse on, it would sometimes stick to the milestones of anesthesiology, and I wouldn't be boring you on the competency frameworks. Rather, I would take a clinical approach where we will discuss some cases and then we'll see how we could structure training. So a case of wrong intrathecal dose where cesarean section was planned for non-progress of labor, and a 2 ml 0.5% bupivacaine and 100 micrograms of intrathecal morphine was planned. Eventually what happened was zero point 0.1 mils of neat morphine, that's about 1 milligram, was directly used, and the patient required naloxone infusions in the post-op. So it could be like a system issue where the wrong drug and the not so written dose was used, and two people were not involved in reading it out. As far as the trainee, he had returned probably from a posting where he had not done obstetrics in the recent past, could not check with the senior who was like going to be a canine who's going to snap anytime you ask anything, and there were no cognitive aids to read it out. So if we look at an intraoperative sedation in a high risk patient, EF is 35%, has a pulmonary systolic pressure of 70, and supracondylar fracture where a brachial plexus was done, and TCI, target control infusion propofol sedation, was started nearly on the max levels, and in 90 minutes the patient has sudden hypotension, desaturation requiring CPR and intubation. So if you look at this, as such, the patient was lying for long, is high risk cardiac, the systemic blood pressure reduces from the sedation and the awareness loss, and hence the LV outlet, LV is compressed by RV hypertension, and there's a cardiovascular collapse, probably phrenic nerve component and hypercarbia is involved. So not just a brachial plexus, the trainee focus should go on to monitoring in such patients and other things of high risk cardiac or patient factors. Now here is a complex post-operative patient, a Whipple surgery, and there is a unique practice here where they do a thoracic epidural for the first 2 days of analgesia. Rectus sheath, which is placed end-op, is usually activated when the patient's catheter is removed and goes to the post-op for about 3 to 5 days use. So when then infusion was stopped for low blood pressure, which is very common in the first post-operative days, one of the instructions the trainee read was flush the catheter and give 20 mils. That was meant for the rectus sheath, but he did it into the thoracic epidural. Patient managed to survive, no issues later on, but then there is a complex post-operative patient. Junior most trainee goes to manage it when there is a call from the ward in the middle of the night. Only two people had such peculiar practices. Their notes were in detail, but it was overwhelming to see a pump which has got a epidural PCA setting, and then there are two infusion running. So learning should include more than just the cases. It could be an acute pain database. How do we teach and train the juniors in the scenarios? Having quick reference guide before they purge. So there's an act of omission, not sorting pain. There's an act of commission, giving a wrong medication at the wrong place. So calling back senior and unfamiliar system is one part here. So here we have a rescue analgesia requirement in a patient who has had an above knee amputation. So in the baseline, there was 3 weeks of struggle with the patient where there's opioid consumption, like literally drinking about 200 milligrams of morphine a day with oxycodone and ketamine on and off. So the regionalist prefers to make a anterior sciatic catheter for some revision. So we give it through the anterior approach somewhere in the mid upper thigh, and 12 hours post-op was trainee goes to see, oh, there's no loss of sensation to cold above the bandage area, so it was deemed procedure as a failure claimed by the patient, and serious communication issues. Well, the injection is given here, the sensation loss will be distally, above that will not be a way of how you check. So it's a complex pain issue. There's polypharmacy, there's psychological dependence, and then the basic pain management drills, rescue pain training, difficult comms training, and escalation when patient is put on when you're put on spot in front of the patient are needed. So looking at 25 epidural experienced trainee who suddenly sees a gush of fluid through the large needle, and then waits for the senior by putting an yellow cap on the epidural needle, which still drips, threaded the catheter intrathecally, and claims first time ever, and 6 hours later patient's back is sore. So notice that actually the crocodile clip has gone off and has been leaking CSF. Obviously in 12 hours the patient has a headache requiring a blood patch. Now here this is an advanced setting, and then the patient had breakthrough pain issues. We think of that as how a spinal infusion would work, but then we have to be prepared for the inevitable. There's always a first, and how we are kind on the post-event training matters, and how they are honest about telling when things happen. And simulation-based scenarios even could be run through before they can have these problems. So my approach to training would be like the 5 P's, where we talk about procedure. We lose so much energy on this. We have to go into proficiency, adding the component of patient-centeredness here, and looking at processes for safety, and don't lose the proceduralist, the persona who's doing it. So procedure related would usually be on the knowledge, the part task as a skill, observing it, and then, well, starting with low complexity and reflection of learning. So in our obstetric training, the first week will be pupil sterilization. Spinal is about 10 to 15, between 8 to 12 in the morning, and that's it. Once you're done with, then only you come to cesarean theta. So reflection on that learning and having a scenario based learning matters. So in the steps of how we acquire the knowledge, there's an anatomical fact, learning it under supervision, and then linking that new knowledge to what we see, working independently, like then adding on to the flexibility to adapt. So this is where continuous training in registrars and senior staff really matters. The learning never stops. So if you look at regional anesthesia knowledge foundation, it has to cross the dermatomes to reach myotome and osteotome understanding for any use. And axillary brachial plexus can be like learned in any sites. For me, my one of the personal favorites is the neuraxiom.com, where you see initially color images, and then you superimpose ultrasound, and as you go more proficient you can do the opposite and learn from it. Not just that, you have to train on your own self to see how the blockade works, and the imaging happens, and then eventually you also look at how the nerve is identified distally, and then you go back. So the knowledge acquisition, I would say, has to be multi-pronged. Starts with textual large information, understand the clinical pharmacology, layer it with functional applied anatomy, and then go on to websites. The USRA is one of my favorites, where you have simple half a page information, very structured, and then you go on to thematic issues on the topics and you learn from there. Eventually it has to move on to the expert opinions. There are multiple YouTube channels now from these two authors, and a handheld device eventually will help you when you have to get quick information, where to place it, above the sheath or below the sheath here in the suprainguinal fascia iliaca. So the skill itself starts from basic needling outside of the patient, probe and functional anatomy in volunteers, and then probably learning through cadavers if you have the option, and then going on to patients, or learning both ways. When you don't do clinically much, you come back to understand that as a skill. So it has to be surface anatomy. When they come to do in a real patient, I actually ask them to roll and feel the nerves. They just look at me and it's like, are you old school? Yes, I am, but you have to put a probe only after that. So pre-scan before they sterile scrub, remark the anatomy before injection after they have cleaned and draped. Pause the screen and ask them to confidently say how they identify what structure is. So if there is that one below this thing, that's not how you do it. You have to label, pause, and state it. After the injection, reflect with them, the trainee, and draw the patient anatomy and discuss variations. So why practice if you have already learned? Because the dimensions of regional anesthesia, such as the theoretical knowledge, patient care, manual dexterity, and confidence, have to be applied and embedded in the skill, and these have to be appreciated as they intersect in the practice. If you look at proficiency related, that is about going from I do not know what I don't know, like unconscious competence, understanding the aha moment of, oh, okay, this is so much that I have to improve, and you use support to learn consciously, become competent, and then you become automatically proficient and expert. Remember to add the patients, such as this pulmonary hypertension of 60, elderly and pregnant patients are different. And for example, I was happy about getting an epidural in an 8 cm patient, cesareans, I mean 8 cm cervix in a labor epidural. And then I came to know humbly that the baby is hypoplastic heart and they're going for a palliative care in the first week of the baby's birth, and have perspectives of the psychological state, remember what prior experiences they had and how that will color them now. The process related ways are, is there even a regional anesthesia block area? How does the induction happen? Does the surgeon believe or thinks LAA works for everything and patients scream in the post-op? Probably yes, that's where we would now train. They're not going to allow us pre-block. Yeah. And post-op monitoring facility itself, who monitors, who gives the top-up, who runs for the problems. And don't forget the proceduralist or the person, the persona itself. Trainee profiling is very important. And can they have a collectedness? Do they have hand coordination and then insight and reflection? So if you look at regional anesthesia modular curriculum, we have to move from the ear and the competency to entrustability, where it's about their progress and not how many years of training they are, like the obstetric intrathecal era. So here, over the next 4 or 5 minutes, we will talk about how, when we take a labor epidural training, how do we structure that itself. So it has to include the physiology of labor, which is the power, the passage, the passenger, and the parturient. And they have to understand the phases of labor analgesia and considerations like before injection, during placement, after catheter placement related issues, and then anytime readiness that we are thinking. There are variables in how someone has to understand labor itself. So technique, the anatomical factors, the labor progress and the stages, and then we have to look at the support system and the maternal and it has to be a structured epidural or simulation based training, where we have after the exposure to anatomy and basic sciences, to part task training with involvement of mannequins, complex scenarios, and interprofessional education with crisis training. So minimum of 10 supervised labor epidurals before we leave them to be able to do on their own. So they need to have an understanding of how a tray or a setting is, and the pre-procedural routines before and after setting up as an automatic way of learning and not just one-off training. When is labor epidural a complex process, like the disease, the clinical concern, and then the precautions? Without this, nobody should be touching a patient who is requiring labor analgesia. And then layer them with issues with prosperity and how there are variations in how that present, and pregnancy is not easy on the spine of a person. Labor can also be tough to understand in terms of anatomy, so doing pre-scanning, ultrasonography, and providing the views of the structures and labeling them is important. Learning them on mannequins or volunteers before drifting the transducers to the side is something very important to understand the midline. Use of spinal instrumentations and previous histories can complicate things. So after understanding all that, one needs to know where the implants are. Is there a space which is free? And then when you perform it actually in real life, you could see that beyond the sacrum, you could only see one space, which is actually an access, and that's one option for them to understand how to do it. Once you add contractions every minute, and then the cervix beyond 7 centimeters where the patient cannot sit to do, that's a different level of complexity in itself. And then needle puncture, which happens into the lumbar area, there needs to be a mind wiring. Like in that case, the yellow cap should not be there and CSF dripping, but they should have a particular way of deciding whether they place a different space or they do it in the same space and then run an infusion. Babies and partogram reading should be at least on par with the obstetricians, if not better. What's a regular variability when they say that it's persistent deceleration, and what is a crash, and then how you have time to manage is an integral part of how an anesthetist works in the labor ward. Breakthrough pain should have systematic way of managing. You are having a lumbar catheter and you want sacral occipito-posterior relief. One needs to understand volume, density, and visceral pain relief before we deem unfit for not conversion. Structuring labor analgesia, training, in summary, includes the theory, the video demo, mannequin tries, scenario-based learning, and staged weaning to supervision to be alone, proficiency, and then entrustability levels. So it's almost like the Thai cave rescue, where people who had 20 more years or 20 or so years only could actually bring this through. We have all those pitfalls while we do the system of labor epidural training, and every day it's given only to people who have had the basic anesthesia skills, the equipments required for the training, the mannequin-based training, EPA guides and readiness for it. First a non-pregnant epidural, then an easy pregnant epidural before they go on this. So retraining and simulation scenarios are important. So are monthly audits and discussions, not to run away from them, but to learn from them, inspiring each other to make your message. And the training should continue in the senior residency and registrar years, where we want to avoid serious errors like using tranexamic acid instead of spinal bupivacaine and having 50% mortality, or having chlorhexidine going through the epidural and patients becoming paraplegic. So continuous professional development and training matters, as skills drop and new knowledge always occurs, and there are better blocks with less complications which we could learn from. And that's where a volunteer practice and crisis training and refresher demos help. So it's not just for the few elite, it has to be an everyday practice for all. So as a department or a system, we need to choose the high value nerve blocks and achieve widespread competence with a few of them at least, and then implement. Then you could look at all the new names. Every day you get a name block that comes. So for example, at least an interscalene for a shoulder, an axillary for below shoulder, and femoral nerve block for hip, and so on and so forth. And we should help them train further where time and opportunity allows. Understand the intrinsic extrinsic barriers. Most of the time there are institutional constraints, not just cost. It's how we'll work around them. So this review article, I liked it for the way it showed an infographic on how the fundamentals, which includes the competency, the part task, and deliberate practice, should eventually reach improved patient outcomes. Along the way, you will have improvements and distractions like web-based learning, artificial intelligence, and eye tracking. What works for you works, and that is how you make the system better. So in summary, training in RA is not just about the trainees and their knowledge, skills, and aptitude training. It's also the teachers, the team, and it should go on to the 4 levels, which is the procedure, proficiency, patient centeredness, the process itself, and the person or the proceduralist. I end my presentation with this small slide on how everything that we do in training should reflect on a learner's dashboard, where we have to go from the knowledge, the skills, attitudes, to how they were part task trained and full-scale simulation enabled, where there is a chance virtually train them, where they could have cognitive deliberate practice, and then we get them through from basic, intermediate, and an advanced and an expert. Thank you, and wish you all a safe journey in regional anesthesia and make patients better. Thank you.
My name is Clara Loeb. I am a Portuguese anesthesiology consultant working in Abu Dhabi. You can follow me on Twitter or Facebook. You can see my handles there. And I'm also sharing my email if you wish to contact me for any questions or discussions. Thank you to Professor Bala for inviting me. It is truly an honor to be part of this 13th AORA. I hope by the end of my lecture you can improve your technique and success rate, as well increase your passion for regional anesthesia. Regional anesthesia teaching is very heterogeneous across Europe and across the world. Minimum standards can vary between 0 to 60 peripheral nerve blocks in general to attest competency by the end of residency. And even more surprising are the minimum numbers of neuraxial blocks, 50, required at the end of residency in the USA, that are less than the ones needed to become a proficient in technique, in the same technique. As you can see there, it's necessary 90 cases for a success rate of 78%. When initially learning ultrasound-guided regional anesthesia, it is common for residents to focus primarily on the hands-on aspects of ultrasound-guided regional anesthesia. However, technical competency alone does not result in proficiency. Either learning general or regional anesthesia, we should aim for SICA. SICA means skills, experience, knowledge. So SICA means skills, experience, knowledge, and attitude. These are the bricks leading to competence and ultimately proficiency. Competence is like medical knowledge, including the risks, knowing the risks, indications, contraindications, clinical pharmacology, effective local anesthetic dose, effects of local anesthetic additives, etc. The patient care, like reviewing the patient's medical history, laboratory results, baseline neurological examination, appropriate regional anesthesia technique plan and anesthetic technique, system-based practice, for example, collecting informed consent, marking site of surgery, procedure timeout, practice-based learning, for example, regular self-assessment, feedback, professionalism, for example, acknowledgement of deficiencies and limitations, ask for help, interpersonal and communication skills like timely documentation, effective communication. All these tools should be used to consolidate core competencies and are didactics, simulation, and clinical experience. Specific topics like clinical pharmacology, risks, and contraindications can be covered through didactics. Other tasks and skills like aseptic technique, vital signs monitoring, patient comfort, management of complex patients or complications, and care coordination with other healthcare providers can be learned through clinical experience. Residents can practice providing informed consent, explaining post-procedural care, discussing management of complications as part of a simulated ultrasound guidance procedure. There are major challenges in teaching and assessing skills expected from practicing anesthesiologists and residents in anesthesia training programs. Implementing appropriate technical actions, technical performance, and manifesting appropriate crisis solving is not enough for a perfect performance. You need to develop and practice anesthesia non-technical skills, vulgarly known as ANTS. You can divide these in two dimensions. One, the cognitive or mental skills, decision making, planning, strategy, risk assessment, situation awareness, and the second is the social and interpersonal affective skills, like knowing how to work within a team, the communication, and leadership abilities. Lapsed or deficient non-technical skills can easily lead to cognitive errors in anesthesia. The good news is that ANTS can be taught and can be trained. Advantages of simulation include the shortening of learning curve, allowing residents to learn at their individual rate, improving success rate. Additional benefits of simulation include learning ANTS and creation of low-stress environment for learning. Can be used to teach certain skills like situation awareness, multitasking, teamwork. Standardized simulation scenarios can allow residents to develop an approach to managing, for example, regional anesthesia complications. This approach has been used by ESRA in our ESRA Residents and Trainees Workshop in Porto, as you can see here on the slides. We just had our 50th event last April. There are several scenarios that we approach during this simulation training, like pneumothorax, total spinal, peripheral nerve block, catheter failure, compartment syndrome, LAST, epidural hematoma, and several other situations. The residents of today will be the specialists of tomorrow, and we need to keep good leaders for future to come. The progression is not the same for everyone. There are some that can progress in supersonic speed and others that might need some more time. It's not important to the step of length or pace of your progression to proficiency, as long as you keep moving and always moving forward. We can find a million ways how things don't work. What is really important is to know what to do if things are not working. So this means you always need to have an escape plan. But before knowing your plan, you need to know the type of failure that the block can have. It can be a total failure, incomplete, a patchy block, a wear-off block, which means that the surgery outlasts the duration of the block, or a misdirect block. How to be successful? You need to know the valid indications, the correct block for the particular surgery, the correct nerve block technique, and to have the correct equipment. I won't delay myself with absolute contraindications, you all know them. And I think there are certain topics that you need to consider before selecting the block for that particular patient and surgery. You need to ask yourself about the morbidity of the technique, the positioning of the patient, if he can tolerate it or not, the technique used to locate the nerve, if ultrasound, if nerve stimulation. For example, nerve stimulation may not be the best one for the patient with a fracture. The type of local anesthetic solution, if you are going to need adjuvants to prolong the block, or if you really need a long duration and you would go for the catheter placement. And also your own experience with that particular technique. Several options are available for the established practitioner to begin to acquire the skill sets associated with regional anesthesia performance. You can start by practicing in accredited events. You can practice ultrasound, scanning techniques, and practice needle insertion techniques using simulators and phantoms. Spend time with experienced individuals, observing and learning techniques, or incorporated ultrasound into a pre-existing regional anesthetic practice. For example, myself, I started using ultrasound and landmark techniques, and then with the appearance of the ultrasound guidance, I included it in my practice. Success, because what do you want? You want an operative anesthesia, you want an operative analgesia, you want only the block for postoperative analgesia. And also by replying to these questions, you can understand what is success for that particular case. There are several conditions that you can establish for knowing which is the best technique. For that, you need to combine the right block with the right surgery with the right patient. You need the right patient, but first you need to meet patient expectations and perception. First, don't oversell the technique. Don't say that everything will be wonderful, that everything will be okay, but explain clearly the advantages, the disadvantages of each technique. In case of failure, what is your plan? And you need to give attention to all details. ASRA has an open web page where patients can find basic information considering regional anesthesia that you can also have a look if you want. Conquer your surgeons is also very, very important, because we all must be on the same side. Usually I can usually I define several steps for establishing a block. So you have to consider your own skills, your knowledge, the patient you have, the technique you're going to perform, and what kind of environment you are practicing in terms of culture and in terms of follow-up and monitoring. For example, you need to know, and for this, doing the technique, you need to know the landmarks, the how to perform needling, the how to expect and control the injection and to spread the local anesthetic, what to expect of your local anesthetic action, and how you will manage post-operatively or post-block. Operator skills and knowledge are very important, and you need to know a lot of things if you want to do properly regional anesthesia. But as important as the amount of knowledge you can accumulate is the need to learn, practice, and train the coordination of your knowledge and incorporate it in your practice and culture. To successfully perform a procedure, ultrasound guided, a triad of 3 distinct but interrelated skills are required: is image acquisition, anatomical interpretation, and the hand-eye coordination. Learning simple and basic techniques can increase your confidence, practice, proficiency, and success. 3 key game changers are: teach high-value blocks, disseminate practice and increase competency, and finally develop the pathway for implementation. The authors of this well-known publication suggest 7 basic blocks that any anesthesiologist should master, and these techniques should be clearly taught during residency. Also, artificial intelligence can be a good help, as there are available softwares that can help you recognize sonoanatomy for the more unexperienced practitioner. But nothing can replace your knowledge of anatomy and the surgical procedure to be performed. Also, it is important to know the nerve architecture, as it can explain the frequency and severity of complications. Proximal blocks are more prone to suffer nerve damage, as their neural tissue content is higher, and they have less non-neural content tissue to protect them. That's why using the correct type of equipment can be so important and can reduce the impact on the rate and severity of nerve damage. Please prefer blunt needles because they can potentially cause less damage. There are several diagrams on the web to help you remember the block distribution for upper limb and for lower limbs. Don't forget that there is more than cutaneous representation. We need to have in mind dermatomes, myotomes, and osteotomes. I'm sharing with you some of the diagrams I personally use. You can find them in the web as well. We have it also for lower limb blocks. But beyond this, you also need to know that visceral organs can also be sources of pain. And pain is dynamic. For example, in labor, the pain can vary in intensity and location, and also you can have different types of pain as the healing process progresses. Usually is more severe close to surgery and mild as the healing occurs. You need also to know the limits of the technique. For example, related with surgery, if there will be used any tourniquet, if there will be graft harvesting, and the extent of skin incision. Considering the patients, you need to know if that technique is appropriate for the particular lung function of that patient, if there is a risk of falls, if there is a risk of compartment syndrome, for example. Knowing the limits of the ultrasound is also very important, as well the most important artifacts, because some of them can give a lot of information for you. Always register if there is any previous nerve injury. Documentation is also very important. You can do, there is a recent publication in Regional Anesthesia and Pain Medicine considering what you should include when you are performing a documentation in terms of patient information, procedure preparation, performance, and specific for peripheral nerve blocks and for neuraxial blocks as well. I invite you to read it. It's very easy to read, and with the tables can help you a lot. It is also important for you to know the guidelines and the recommendations when you want to perform regional anesthesia in anticoagulated patients. You can follow international guidelines, or you can follow your own guidelines nationally or from your institution. Monitoring is also very important. You can speak of multimodal monitoring. That means combining different types of monitoring in order to provide you the most information and to give you the availability or reduce the risks, although there is no evidence of better outcomes when these monitoring, triple monitoring is combined. I will not extend myself telling you about the advantages of using ultrasound for regional anesthesia. The ease of accurately performing neuraxial blockade with direct visualization, navigation, and targeting of nerves is ultimately appealing, and it can be used in challenging anatomy like obese, scoliosis, diabetic, pediatric, and several situations. I also want to remind you that and recommend you that aiming directly to the nerve when you are progressing the needle is associated with a high incidence of intraneural injection. So instead, you should aim for a tangential approach, and this means that if you are close to the nerve and he will slide in front of your needle instead being transected by it, reducing, of course, the rate of intraneural injection. Positioning is extremely important. Well, maybe this is my neck and it might not be the best example, but I can show you with a short video that moving the head towards the contralateral side and asking the patient to reach for the knee will increase the length of the neck and will expose better the area where you can scan and perform your block. Also, if the patient is lying down, you can put a cushion below the scapula in order to increase the space between the shoulder and the table, and so you can easily manipulate the needle and position your hand. There are certain nerves that you cannot see it all the time. Even experts may miss them, and but you know that they are usually positioned in certain areas. For example, the long thoracic nerve and the dorsoscapular nerve are across the middle scalene muscle in the interscalene area. So in plane progression of the needle through the belly of this muscle can inadvertently damage these nerves. So I would instead advise you to have a more steep approach or prefer a more superficial approach to this muscle in order to avoid transecting the nerves inadvertently. Also, position for lower limbs in terms of exposing the sciatic nerve block using the Sims position can be quite advantageous, especially in very obese patients. The popliteal block, and I need to really, considering the tourniquet use, is it possible or not to use it when you are performing a popliteal block, especially for ankle procedures or foot procedures? Yes, it is possible, but there is a special attention. I want to bring your attention this special item that placing the tourniquet on the calf area can be hazardous if you place it over the head of the fibula. In the close to the head of the fibula, you have the common peroneal nerve, and the high pressure of the tourniquet can cause severe damage and a drop foot after surgery. So I would advise you to look for the head of the fibula with the ultrasound, as you can see here in the image. You can mark it on the skin, and when the placement of the tourniquet, place the tourniquet in a more safety way. The epidural block has several reasons for failure, like the incorrect primary placement, migration, or suboptimal dosing. But you should be highly suspicious in several situations where the probability to failure is very high, especially in obese, longer gestation duration, higher parity, whenever more top-ups are needed during labor, when high pain scores during last 4 hours, or patients with a previous back surgery. Correct placement is paramount. As you know, epidural is a segmental block. There are several guidelines also that you can follow to help you choose the best level for each type of surgery. Lateralized blocks occur more frequently with a higher thread of catheter, especially over 5 centimeters, and also secondary dislodgement in very obese patients when only change in position can dislodge the catheter in 24% of cases. Especially in obese, when moving from sitting to lateral, the catheter can move between 1 to 3 centimeters. The spinal block can also have problems with a misplaced injection, and it's especially it's especially frequent in pencil point needles, especially when the hole of the needle is not placed in its totality inside the intrathecal space. So what happened, and you can see here on the right side of the image, you aspirate and you get spinal fluid, but when you inject, the DORA functions like a valve, and the local anesthetic is injected not in the CSF but in the epidural space or in the subdural space. You all know that blocks need time to work. Please do it in a timely way. You can bring the patient earlier to the OR and perform the block, because you need at least 30 to 45 minutes to have a correct full establishment of it. The block room is a perfect place to do this and to perform and assess the block, and also to rescue or repeat in case of failure or deficient placement, and also is important to improve OR efficiency. The rescue blocks, why? Yes, so you supplement an incomplete proximal block, or you can provide the postoperative analgesia. For example, in a proximal block, you use a short-acting local anesthetic, and for a distal block, you use a long-acting local anesthetic, providing a more targeted analgesia postoperatively and reducing a higher area of block that could be unsatisfying and disappointing for the patient. Another important aspect is, do you want an awake patient? Or in another way, is that patient a good candidate for sedation or not? Light sedation, of course, you can do it, but sometimes it's really hard to draw a frontier between the different levels of sedation. But you can, distract patients, and these are my patients. They allow me to take their pictures, so you can let them bring their own music, you can let them read, you can talk to them like I did with this lady on the left side, or you can just give them their cell phones and they just can chit chat. So I think we should dream big as my take home lessons. They implement early in residency basic regional anesthesia techniques can increase a lot the confidence of future specialists in anesthesia and regional anesthesia, and give them the confidence and enthusiasm to learn more. Meet patient expectations and conquer your team. It's very important to have a healthy and comprehensive environment and culture. The ultrasound guidance should be the gold standard for learning and performance of these techniques. Creating and developing pathways for quality teaching is paramount, not only for starters but also for the ones who want to consolidate their knowledge. Following guidelines and keeping a curious spirit and open attitude can help a lot, especially if you want to learn and keep updated for the most evidence-based practice. And be vigilant and attend all details. And of course, this involves a lot of personal investment. But what a better recognition than to be and entitle yourself as a regional anesthetist. And so this is my last slide. I just want to invite you for our World Congress next September in Paris, and I'll be happy to answer all your questions and any discussions you might have. Please send me your email and send me an email, and I'll be happy to reply. Thank you very much for your attention, and hope we can meet soon.
Hello and welcome. I'm very happy to be at the AORA conference and have the opportunity to tell you about my new mantra in education, which is safety rather than mastery. I've been teaching ultrasound guided peripheral nerve block for quite some years, and for many years I tried to tell people that it was very easy, and I didn't understand what they could see. They should just put the needle in the vicinity of the nerves as they saw on the screen. But after a number of years, I've changed my attitudes, because I think that safety rather than mastery is much, much more important. We need to make sure not to make complications for our patients. I know that we can never have zero complication. When we do a lot, things will happen. My name is Bo Gottschau. I'm from Denmark. I am a specialist since 1993. A strange number to see and number to say, because that's a long time I've been around. I have been working with ultrasound, and it's working at the University Hospital. We are joint hospital. Herlev Gentofte University Hospital. Herlev is the acute hospital. Gentofte is a planned surgery hospital, which you see on the picture on the screen. I've been working with peripheral nerve blocks through a lot of years, and for 17 years, it says here, with ultrasound. Actually, it is 18, but we can work with that. We do. I have a number here from 2006 to 2021, which is approximately 50,000 blocks, individual blocks, and and that means that is both the post-operative pain management blocks and the surgical blocks, where we do not give them any sedation during the operation. We do a number of catheters, but very few, because we have realized that in our hand, in our institution, we have a good duration of our blocks, so that we can put in another block if necessary, and the number who needs the second block is very low. My key interest is in education and certification and complications, safety. 60%, as I show you, I'll just go back once and tell you that 60% of those blocks are for surgery. That means that a majority of our blocks is surgical blocks. Safety rather than mastery, we know what we're talking about. We're talking about these nerves which we do not want a damage. We do not want to get under the epineurium, and especially not under the perineurium, where we know that if we get in there, the chance of damaging the patients is very big. When we have seen through time, this is a Brian Side paper and Vincent Chan paper back from 2009, and that is repeated over and over again, that what is the most important thing, what should be in focus, what do we need to be aware of, that is the needle tip. The needle tip is the thing that do the damage. So above all, safety rather than mastery. Still picture and ultrasound, that is not compatible. That is not something we want. We want a live picture. We want to confirm what we are seeing. We have to verify, and then make a decision and put our needle close to the nerve, not under the epidural, but maybe close to it, so that it's under the fascia, so that the local anesthetic is close to the nerve, but not under the epineurium, so that we see an expansion of the integrity of the nerve. We know that we can be enthused and we can see pictures on YouTube, but YouTube is a place where you can go, especially when you know quite a bit. It's not a learning place where you start up from. Then you will be very surprised what you see on your patients, because a lot of the pictures on YouTube are very clear and looks very easy, and it is not that easy as it's shown on a lot of the YouTube videos. Of course, that's good and well known, but I think we should be a little careful to learn things on the internet. We need bedside education. We know that we do not need to go too close to the needle, and we know that when it goes wrong, if we have complications, we need to know how to deal with it. We need to have a setup in our institution where we make sure that the patient is taken care of, so they can trust that even though something happens, either whether it's a surgical problem or anesthesia problem where we have damaged something, or so that there is an impairment on the patient, we need to take care of the patient. A picture like this could be from the YouTube, which shows the scalene groove very, very clearly. But when you look at a lot of patients, it's not as clear as this. So and a still picture again is not interesting, and we need to move the probe so that we go down to the supraclavicular block and follow the nerves up so that we see the roots appear, and make sure we see C7, C6, and C5, and we need to follow them intrinsically so that we know where we do not want to be, and so that we can put it. And in my mind, we should put it out of plane, because we can keep us in the backside of the roots with no direction of the needle towards the roots. Do no harm is important. Here's three examples where we have patients where things has gone wrong. Here we have a patient which the day before got a shoulder prosthesis, and at the end of the operation we realized that the hand was very pale, and we ultrasound scanned it and could see that there was a occlusion of the artery supply to the arm. So we got her to a bigger hospital, and she was operated 6 hours to get the clot out, and she came back the day after with this picture. It took almost a year before it came back, but it came back, and we made a lot of tests on her, and it showed that it was the surgeon who had made a suture around the artery and some nerves, which means that we were very lucky because we had I put a scalene in for the operation, and when we realized that he had to go to the surgical surgeon, the vascular surgeon's department to solve the problem, I was afraid that he needed to wait a long time, so I wanted to dilate the vessels. So I put in a second scalene there, and that's debatable. We can discuss that another time when we meet. But everything locked out, and we have followed her through the years. She has got 2 new stents in, two other operations, but she is fine today. In the middle, we have a patient with a beetle syndrome, which was operated in the elbow, and she came back with a malfunctioning arm, a young woman of the age of 22, which has she has some extreme pain when she's operated on, so we have a very hard time serving her, but we are following her, and it is resolving very slowly. The gentleman on the right-hand side is a young man that was back in 2007. I performed the scalene block, and afterwards she thought it was a great block. He has no pain or whatever, but he could not lift his arm. He could use his fingers, but it turned out that I had been in the C6 route, and that lasted for 19 months before he got his function back. We were so lucky that we have had the opportunity to follow him every 3 months, and he had been coming back, and he even broke the contralateral, the other side's clavicle, and he came in and asked if I would give him the anesthesia for the operation. So that was a very lucky situation too. How close is safe? That's another good question. You can see that here we have a picture too. It's a very shallow, it's the median nerve on the forearm, and we are putting the block around the median nerve. It's in 1 centimeter depth, and we can see that we are very, very close to nerve. This is probably also an example of a too clear educational block, because it's not always that clear to see the local anesthetics around the nerve. We have gone down in concentration in our local anesthetics, but a little up in volume. We are going a little back to that we have the volume so that we can make more of a donut spread around our nerves. And of course, on the left-hand side, we have a picture of a place where we do not want to be. Here we are under the perineum, and we don't want to be there. It's easy to perform ultrasound-guided peripheral nerve blocks, but it's not that easy. We need to accept that sometimes it's difficult. We can have a patient who's have a constitution where it's very difficult to see through the skin and to use the ultrasound, and that means that we have to be satisfied with a non-working block where we need to draw back and say we cannot perform this. We would rather have an incomplete block than an impaired patient. We need to practice before puncture. Practice, 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 and bedside education. I'm in favor of out of plane, but out of plane, in plane, laxer sacs. In skilled hands, it doesn't matter. And if the educational support is good enough, it doesn't matter. But in our place, in our institution, I teach out of plane technique, because I think that with the out of plane technique, you get more skilled, because you need to understand that what we're working with is a plane, and you need to be in plane. You need to see the needle tip, move the probe so you don't see it. Actually, when you do not see the tip of the needle, that's where you know where you are, because then you have followed out over the side of the needle tip. This is the ultrasound plane, and we see a spot on our ultrasound machine, sorry. And if we follow it along the needle, we see it as the same, a little deeper. And when we get out in front of our needle, then it disappears. And that is where we go back and forth. And this article is a very nice article by Louise Clemenson, which I support my reason for using out of plane technique, because it shows that even in unskilled hand, you learn it faster, and that in plane technique there's a chance that you see the shaft and you think that's the needle tip, but actually you are in the no plane technique where you do not see the needle tip. So that's the reason for that. We use, as I always say, the axillary block as our primary educational block. In our grade 1 qualifications at our institution, we have the axillary block always, then we have the duct canal and popliteal block as the 3 major blocks where you have to perform those. In the axillary block, there is the great advantage that there is 65% of anatomical variations. No, that's a lie. 35% of the anatomical variations. That means that every third is not as it's described in the textbook. And that makes it a very good educational block, because you need to show me where the nerves are and how they run. You can follow them all through the upper arm, and you can follow them the antebrachium too. And you have 5 nerves, you have muscles, you have vessels, and that makes you a little humble. Our complications at our institution is something we take very seriously, and we have been lucky to have only 3 permanent nerve damages out of our 40 blocks, which we know of. It's important to say which we know of, because there's a dark number, because there might be patients who are not coming back, who are going to other places if they have a nerve damage. So that's important also to be aware of, that there might be a literature reference of 0.02 to 0.4%, but there might be some who do not come back. Toxicity at our institution, very few. We have used lipid emulsion twice on cramps and confusion. We have no cardiovascular collapse or myocardial depressions during the last 7 years. And when we go back to our patient, as I told you, the first patient there, that is 1 year after her surgery, that was completely impaired musculocutaneous and sensibility. She had some motor function, and I asked her to move her hand if possible, and you can see that it's nice on it, and she can suddenly move it, and we get very happy for her. And the same thing we can see the gentleman where I made a C6 damage back in 2007. I called him for a meeting 10 years after, where he came and explained, because in my educational portfolio where I talked about his case, I've always told it as a very positive case, because he was out mountain biking again. And now I wanted him to come back and tell us how he experienced it. And he could tell us that he thought that it has been a very tough period, and he had to quit his studies, and he was delayed in his education, but he came out on the other side, and he's mountain biking again. And as I told you, he broke the other arm, which you can see on the lower part of the picture, and he came for a new blog with us later on. But to come back with the 10 years after interview, he told us that what happened was he was on gabapentin for more than 2 years, and his family thought he has gone a little weird, or that is influenced on his psychological status with this 19 month of impairment of his hand. But when he got rid of his gabapentin, he came back and was his normal self. So what we did was that after we had left him after 19 months of following him up in our ambulatory, we led him to the general practitioner to take care of his medication. And the general practitioner is not aware of detailed in gabapentin medication. So now we have, because of this, every patient who come, which we send out to the general practitioner, they get a phone number so that if something happens, they can contact us. So we have a chance to try to modify the medication to the patient's benefit. And the last picture I have here is this young lady who's just came back. She has her arm. She's back at work. Fortunately, she got a little function back, and we have made a lot of neurophysiological tests, and there's no cut off of the nerves, and it's coming. But this is after six months, and we hope to have a continuation to see that it comes all the ways back. She is working she's working in an office, and she can use the thumb and the second finger, the index finger, to type with. It's a very tough young lady. Thank you very much.
Dear colleagues, dear friends attending us on the other side of the net, good morning from my side. I am Eleni Moka. I am a consultant anesthetist from Greece, and I currently represent the European Society of Regional Anesthesia and Pain Therapy from the position of incoming president. My presentation will focus on diversity, equity, inclusivity, and how they can influence regional anesthesia practice. Before starting my talk, I would like to congratulate the organizing and scientific committee for this wonderful Congress, as well as to thank them for the honoring invitation. So, directly entering into the topic in the 20 minutes that are allocated to my presentation, I will try to first of all discuss the fundamental working definitions of the concepts of diversity, equity, and inclusion, and how these terms interrelate between each other. I will also explain you briefly on how inclusivity may influence regional anesthesia practice in terms of benefits, challenges, and barriers. And finally, I will focus on how regional anesthesia scientific societies can promote DEI and may contribute to optimal patients' care, advancing finally healthcare and health equity. So, moving on to the terminology regarding inclusivity into our practice and to the fundamental working definitions. In simple words, first of all, we need to understand some terms. Disparity is a significant adverse difference in health status or related outcomes between population groups, and can become inequality when this adverse difference happens due to unequal access to resources or difference in distribution, and it can further become inequity when this unequal access to resources is fully unfair. It is true that disparity, inequality, inequity are terms that are interchangeable in daily practice and are often regarded as synonyms. It is true also that there is a transatlantic language divide. Why? Because in the United States, disparity is generally used for differences related to ethnicity or race, whereas in Europe, inequality is used in the context of socio-economic differences. It is important, though, that in the United States, the concept of disparity is now becoming closer to the definition of inequity. And in simple words, let's see what's the difference between equality and equity. Equality is when everyone has access to a particular resource, and this also applies to healthcare, to medicine, to anesthesia practice, whereas equity is when this access to the resource takes place in a way that it is right for them, for the people, and this is very important to understand this clear difference. In addition, diversity, equity, and inclusion are interconnecting and overlapping aspects. They are not the same thing. Diversity of people or perspectives is an outcome. It is different from equity, that is a process regarding freedom from bias or from favoritism and parity across differences, whereas again inclusion via power, voice, and culture is an outcome. And finally, inclusivity, that means providing equal access and opportunities and resources for people who might otherwise be excluded or marginalized, is clearly a practice and a strategy, if not a policy. And of course, the main question that comes to the table is how inclusivity and diversity can influence regional anesthesia practice. The answer is very simple, and in my opinion, comes from the title of this very successful, this clever article published in ASA Monitor back in February of 2023. According to the authors, inclusivity and diversity in healthcare is the pathway to building belonging, better care, and a healthier working environment. And if you wonder how this can happen, because the concept is quite complex, I really advise you to look into this special article on diversity and inclusion in our specialty published last year. According to the authors, inclusivity may offer advantages for both the provider and the institution, but mainly for the patients themselves. How this can happen? For example, when we have an expanded workforce diversity, we can have innovation, creativity, increased engagement from the provider, the ability to solve complex problems, increased efficacy, wellness, job satisfaction, reduced percentages of burnout, increased productivity, reduced absenteeism, talent optimization, financial stability, and profitability for the institution. In other words, we can reach excellence, a situation where every provider has the opportunity to attain their full potential. And as a result, we can have patient advantages like improved access to quality care, reduced health disparities and care inequalities, and improved outcomes, meaning offering safe and equal treatment opportunities to every patient, reaching finally the health care, but most importantly, the health equity. And it is true that in our specialty, the ideal scenario should look like what we see in the slide, not only to have equity, but to move further to the concept of belonging. However, the reality is fully different in our practice and much more disappointing. Why? Because we have data about healthcare inequalities in relation to the regional anesthesia provision. In the United States, clearly racial, ethnic, gender, and insurance disparities have been identified in the provision of regional anesthesia in orthopedic surgery. It is very disappointing to see that minority patients may be more than twice as likely to receive a general anesthetic versus white patients in total hip and total knee arthroplasty. In addition, only 6% and 16% of Black patients have the chance for peripheral and central nerve blocks, respectively, for hip fracture surgery. Female patients are 11% less likely to receive regional anesthesia versus male ones, whereas patients with Medicaid insurance are almost 40% less likely to receive regional anesthesia techniques versus those with a private insurance. The same disappointing conclusions are coming from the obstetric anesthesia cohorts in relationship to the regional anesthesia rates and its application. Why? Because Black and Hispanic women are more likely to receive a general anesthetic for cesarean section. But also we can have racial disparities in pain management across disciplines, with Black patients consuming far lower mean annual opioid dose versus white patients. And one would wonder if these data are similar in the European continent. It is true that we do not have data from Europe because we do not have the large databases and the large registries that exist in the US. In addition, applicability of the US data is not possible due to different ethnic demographics in the European Union. It is true that the healthcare system between United States and Europe is fully different. In the US, it is privately operated with access by insurance and with 14% of the population being uninsured, where access to care in Europe is independent of the ability to pay and is delivered via the NHS. However, even in Europe, we can see some publications that show us that probably disparities in the provision of regional anesthesia exist. For example, we have this article published in 2023 by the group of Nuala Lucas, based on the records of more than 6 million births from the National Healthcare System database in an effort to investigate the association between ethnicity and the provision of care in obstetric anesthesia in a 10-year period. And it seems that disparities indeed exist, at least in the obstetric anesthesia care. Why? Because in the case of elective cesarean section, general anesthesia can be 58 and 35% more common in Black Caribbean and Black African women, respectively, versus white women. In emergency cesarean section, a general anesthetic is 10% more common in Black Caribbean versus white women, whereas in labor, Bangladeshi, Pakistani, and Caribbean parturients are 24, 15, and 8% less likely versus the white women to receive a central neuraxial block. And because in Europe we have circulation of population with the immigrants arriving in the European Union, there are publications comparing the provision and the appropriateness of healthcare between immigrants and non-immigrants originating from Germany. And according to the authors, involving more than 6,000 patients, it seems there is an under-provision of care in women, mainly in first-generation immigrants, in those with reduced language proficiency and reduced educational attainment. And when the healthcare providers were asked about the reasons for this fact to happen, the top reasons for a lower rate of epidural anesthesia in the obstetric population was the fear on the part of the immigrant women in 64% about the technique and in 50% the language barrier. It seems also that we have the disparities not only in the provision of care, but in the workforce environment. And unfortunately, the current status in both the United States and Europe is quite disappointing. We can see the demographic composition of anesthesiology in the academic environment and in the resident cohort, and we notice that women represent only around 30% of these cohorts. And more disappointingly, Black and Hispanic population are around the 5% of the academic faculty cohort and the anesthesiology resident cohort as well. In addition, less than 6% of full professors in all specialties are from underrepresented groups. Women make up at maximum 7% of full professors and 14% of department chairs, and we notice a very low percentage of women as board examiners. So we have a problem, and when we have a problem, we are obliged to identify the etiology, and the etiology of the disparities that have already been presented has to do with the patient, the provider, the systems, and the policy. In the case of patient, it is important to remember that we have different norms and standards, lack of quality information or misinformation, language barriers, social influences, and a reduced health literacy level. In the case of the provider, important reasons are the bias, implicit or in-group stereotypes, the microaggressions, the cultural competence, and the lack of availability of workforce disparities. Whereas in the case of systems and policy, we identify as reasons the service availability and accessibility, the system bias, the lack of cultural support, and again, the language barrier. So when we have the etiology, we need to find the solution. And it is true that achieving greater health equity should be an opportunity for our specialty. And when I say opportunity for the case of regional anesthesia, I mean regional anesthesia provision everywhere. But in order to achieve this, we need not only a vision, we need a clear strategy and a concise plan based on a multi-level interdependent framework as it is presented in the slide. This relies on an iterative cycle starting from the patient and then moving to the clinician, to the group, the department, the healthcare organization, but also to the scientific associations and to the specialty societies in an effort to identify the health and healthcare disparities, to focus on social determinants of health, achieving finally healthcare and health equity via various steps like optimization of care, application of regional anesthesia and ERAS programs, documentation of improvement in healthcare access and health outcomes, and of course, by having a cultural competency and a group diversity. It is beyond the scope of my talk to analyze you all the steps that have been presented via the iterative cycle. I would like more to focus on the role of the regional anesthesia scientific societies in achieving healthcare and health equity, because I believe they could serve as key drivers. And what they can do, first of all, before doing anything, we need to understand that diversity does not automatically lead to inclusivity. We need a pathway, an organizational evolution away from disparity and towards equity. And this includes various steps like securing leadership buy-in, identifying common goals, and developing a common policy, a common strategy and plan, applying an oversight structure to make the policy visible, collecting and reporting data to monitor our performance, and most importantly, engaging dialogue to develop interventions that could mitigate the disparities if we want to respond to resistance and take the pledge. And in this concept, the European Society of Regional Anesthesia has welcomed an article by the blog This Girl Blogs in its newsletter, whereas the author discusses on how to narrow the gender gap and to support women in the field of regional anesthesia. The Royal College of Anaesthetists has created a committee on equality, diversity, and inclusion. The same applies to ASRA, focusing on the role of women in regional anesthesia and pain medicine, but also to the Society of Obstetric Anesthesia and Perinatology, because they created not only a committee, but published also a diversity and inclusivity statement. And in this context, the most important when we discuss about RA societies is the possible partnership initiatives. We need to establish joint DI committees, scientific interest groups, and create joint task force on inclusivity to ensure that membership, leadership, and programming reflect the diversity, to provide the resources and guidance to members and leaders as far as implicit bias and microaggression, and most importantly, to develop and release common guidelines and position statements that could serve as a standard for best practices in the field of DEI. In addition, the societies, by partnering between each other, they can organize combined education and networking opportunities to foster cultural competency and diversity training to providers in an effort to understand the social determinants of health in the perioperative setting, to enhance the culture of belonging and to reduce stereotyping and bias, to promote health policy education in order to effectively advocate for patients, and of course to implement patient education programs to increase the knowledge of patients on best practices for accessing regional anesthesia care, for a knowledgeable participation in treatment decision. And it is also important to translate informative material in various languages so that we can enhance the health literacy level in every patient population. Finally, it is extremely crucial when partnerships are created between regional anesthesia sister societies to organize common advocacy for policy changes by raising at the beginning the awareness, by promoting the diversity, and by encouraging the healthcare institutions to recruit and retain providers from diverse backgrounds and to offer training for all. Then by creating supporting working environment to provide resources about work-life balance, workplace discrimination, harassment, and finally by engaging and collaborating patients groups to gain insights of their needs and perspectives. If we finally want to advocate and have an advocacy, a policy advocacy with guidelines on language access, on patients with disabilities, and on cultural competency. To conclude, as a summary, as a take-home message, I would say the title of this excellent editorial of Paloma Toledo, published in 2022, according to which we can expand our horizons and as anesthesiologists, we can improve health equity. In order to achieve it, we must think of our practice at the population level. We need to make partnership between scientific societies because by this way we can contribute to health equity and universal health coverage. But in order to achieve it, we need a framework and a clear strategy. The society leaders must make efforts to remove barriers, but they need to remember that it takes perseverance, commitment, and multiple recruitment cycles. All in all, the most important conclusion, in my opinion, is that equity in our subspecialty, in regional anesthesia, but also in anesthesiology, needs to be embraced from the top if we want to be very successful. And at this point, I would like to stop and thank you for your attention, but also to invite you to the World Congress of Regional Anesthesia and Pain Medicine that takes place in Paris in September, where Many topics regarding disparities, diversity, and inclusivity will be discussed. Thank you very much for your attention. To the authors, inclusivity may offer advantages for both the provider and the institution, but mainly for the patients themselves. How this can happen? For example, when we have an expanded workforce diversity, we can have innovation, creativity, increased engagement from the provider, the ability to solve complex problems, increased efficacy, wellness, job satisfaction, reduced percentages of burnout, increased productivity, reduced absenteeism, talent optimization, financial stability, and profitability for the institution. In other words, we can reach excellence, a situation where every provider has the opportunity to attain their full potential. And as a result, we can have patient advantages like improved access to quality care, reduced health disparities and care inequalities, and improved outcomes, meaning offering safe and equal treatment opportunities to every patient, reaching finally the health care, but most importantly, the health equity. And it is true that in our specialty, the ideal scenario should look like what we see in the slide, not only to have equity, but to move further to the concept of belonging. However, the reality is fully different in our practice and much more disappointing. Why? Because we have data about healthcare inequalities in relation to the regional anesthesia provision. In the United States, clearly racial, ethnic, gender, and insurance disparities have been identified in the provision of regional anesthesia in orthopedic surgery. It is very disappointing to see that minority patients may be more than twice as likely to receive a general anesthetic versus white patients in total hip and total knee arthroplasty. In addition, only 6% and 16% of Black patients have the chance for peripheral and central nerve blocks, respectively, for hip fracture surgery. Female patients are 11% less likely to receive regional anesthesia versus male ones, whereas patients with Medicaid insurance are almost 40% less likely to receive regional anesthesia techniques versus those with a private insurance. The same disappointing conclusions are coming from the obstetric anesthesia cohorts in relationship to the regional anesthesia rates and its application. Why? Because Black and Hispanic women are more likely to receive a general anesthetic for cesarean section. But also we can have racial disparities in pain management across disciplines, with Black patients consuming far lower mean annual opioid dose versus white patients. And one would wonder if these data are similar in the European continent. It is true that we do not have data from Europe because we do not have the large databases and the large registries that exist in the US. In addition, applicability of the US data is not possible due to different ethnic demographics in the European Union. It is true that the healthcare system between United States and Europe is fully different. In the US, it is privately operated with access by insurance and with 14% of the population being uninsured, where access to care in Europe is independent of the ability to pay and is delivered via the NHS. However, even in Europe, we can see some publications that show us that probably disparities in the provision of regional anesthesia exist. For example, we have this article published in 2023 by the group of Nuala Lucas, based on the records of more than 6 million births from the National Healthcare System database in an effort to investigate the association between ethnicity and the provision of care in obstetric anesthesia in a 10-year period. And it seems that disparities indeed exist, at least in the obstetric anesthesia care. Why? Because in the case of elective cesarean section, general anesthesia can be 58 and 35% more common in Black Caribbean and Black African women, respectively, versus white women. In emergency cesarean section, a general anesthetic is 10% more common in Black Caribbean versus white women, whereas in labor, Bangladeshi, Pakistani, and Caribbean parturients are 24, 15, and 8% less likely versus the white women to receive a central neuraxial block. And because in Europe we have circulation of population with the immigrants arriving in the European Union, there are publications comparing the provision and the appropriateness of healthcare between immigrants and non-immigrants originating from Germany. And according to the authors, involving more than 6,000 patients, it seems there is an under-provision of care in women, mainly in first-generation immigrants, in those with reduced language proficiency and reduced educational attainment. And when the healthcare providers were asked about the reasons for this fact to happen, the top reasons for a lower rate of epidural anesthesia in the obstetric population was the fear on the part of the immigrant women in 64% about the technique and in 50% the language barrier. It seems also that we have the disparities not only in the provision of care, but in the workforce environment. And unfortunately, the current status in both the United States and Europe is quite disappointing. We can see the demographic composition of anesthesiology in the academic environment and in the resident cohort, and we notice that women represent only around 30% of these cohorts, and more disappointingly, Black and Hispanic population are around 5% of the academic faculty cohort and the anesthesiology resident cohort as well. In addition, less than 6% of full professors in all specialties are from underrepresented groups. Women make up at maximum 7% of full professors and 14% of department chairs, and we notice a very low percentage of women as board examiners. So we have a problem, and when we have a problem, we are obliged to identify the etiology, and the etiology of the disparities that have already been presented has to do with the patient, the provider, the systems, and the policy. In the case of patient, it is important to remember that we have different norms and standards, lack of quality information or misinformation, language barriers, social influences, and a reduced health literacy level. In the case of the provider, important reasons are the bias, implicit or in-group, stereotypes, the microaggressions, the cultural competence, and the lack of availability of workforce disparities. Whereas in the case of systems and policy, we identify as reasons the service availability and accessibility, the system bias, the lack of cultural support, and again, the language barrier. So when we have the etiology, we need to find the solution. And it is true that achieving greater health equity should be an opportunity for our specialty. And when I say opportunity for the case of regional anesthesia, I mean regional anesthesia provision everywhere. But in order to achieve this, we need not only a vision, we need a clear strategy and a concise plan based on a multi-level interdependent framework as it is presented in the slide. This relies on an iterative cycle starting from the patient and then moving to the clinician, to the group, the department, the healthcare organization, but also to the scientific associations and to the specialty societies in an effort to identify the health and healthcare disparities, to focus on social determinants of health, achieving finally healthcare and health equity via various steps like optimization of care, application of regional anesthesia and ERAS programs, documentation of improvement in healthcare access and health outcomes, and of course, by having a cultural competency and a group diversity. It is beyond the scope of my talk to analyze you all the steps that have been presented via the iterative cycle. I would like more to focus on the role of the regional anesthesia scientific societies in achieving healthcare and health equity, because I believe they could serve as key drivers. And what they can do, first of all, before doing anything, we need to understand that diversity does not automatically lead to inclusivity. We need a pathway, an organizational evolution away from disparity and towards equity. And this includes various steps like securing leadership buy-in, identifying common goals, and developing a common policy, a common strategy and plan, applying an oversight structure to make the policy visible, collecting and reporting data to monitor our performance, and most importantly, engaging dialogue to develop interventions that could mitigate the disparities if we want to respond to resistance and take the pledge. And in this concept, the European Society of Regional Anesthesia has welcomed an article by the blog These Girl Blogs in its newsletter, whereas the author discusses on how to narrow the gender gap and to support women in the field of regional anesthesia. The Royal College of Anaesthetists has created a committee on equality, diversity, and inclusion. The same applies to ASRA, focusing on the role of women in regional anesthesia and pain medicine, but also to the Society of Obstetric Anesthesia and Perinatology, because they created not only a committee, but published also a diversity and inclusivity statement. And in this context, the most important when we discuss about RA societies is the possible partnership initiatives. We need to establish joint DI committees, scientific interest groups, and create joint task force on inclusivity to ensure that membership, leadership, and programming reflect the diversity, to provide the resources and guidance to members and leaders as far as implicit bias and microaggression, and most importantly, to develop and release common guidelines and position statements that could serve as a standard for best practices in the field of DEI. In addition, the societies, by partnering between each other, they can organize combined education and networking opportunities to foster cultural competency and diversity training to providers in an effort to understand the social determinants of health in the perioperative setting, to enhance the culture of belonging and to reduce stereotyping and bias, to promote health policy education in order to effectively advocate for patients, and of course to implement patient education programs to increase the knowledge of patients on best practices for accessing regional anesthesia care, for a knowledgeable participation in treatment decision. And it is also important to translate informative material in various languages so that we can enhance the health literacy level in every patient population. Finally, it is extremely crucial when partnerships are created between regional anesthesia sister societies to organize common advocacy for policy changes by raising at the beginning the awareness, by promoting the diversity, and by encouraging the healthcare institutions to recruit and retain providers from diverse backgrounds and to offer training for all. Then by creating supporting working environment to provide resources about work-life balance, workplace discrimination, harassment, and finally by engaging and collaborating patients groups to gain insights of their needs and perspectives. If we finally want to advocate and have an advocacy, a policy advocacy with guidelines on language access, on patients with disabilities, and on cultural competency. To conclude, as a summary, as a take-home message, I would say the title of this excellent editorial of Paloma Toledo, published in 2022, according to which we can expand our horizons and as anesthesiologists, we can improve health equity. In order to achieve it, we must think of our practice at the population level. We need to make partnership between scientific societies because by this way we can contribute to health equity and universal health coverage. But in order to achieve it, we need a framework and a clear strategy. The society leaders must make efforts to remove barriers, but they need to remember that it takes perseverance, commitment, and multiple recruitment cycles. All in all, the most important conclusion, in my opinion, is that equity in our subspecialty, in regional anesthesia, but also in anesthesiology, needs to be embraced from the top if we want to be very successful. And at this point, I would like to stop and thank you for your attention, but also to invite you to the World Congress of Regional Anesthesia and Pain Medicine that takes place in Paris in September, where many topics regarding disparities, diversity, and inclusivity will be discussed. Thank you very much for your attention.
Greetings of the day. I want to thank the organizers for giving me this opportunity to talk about regional anesthesia practices in pediatrics. My name is Dr. Nivedita Karupaya. I'm one of the staff anesthesiologists and assistant professor at the Department of Anesthesia and the Department of Pediatrics with Western University. The London Health Sciences Centre and Children's Hospital is a tertiary referral centre in the City of London in Canada. Yes, we have a London in Canada, and we also have the River Thames running through it. The Children's Hospital does between 8,000 to 9,000 pediatric cases in a year, and we're associated with the University of Western Ontario. My objectives for today are to discuss the safety of regional anesthesia in pediatrics, some differences in pediatric and adult regional practice, how to plan a block for a child, and controversies and debates. The use of regional anesthesia in pediatrics is becoming more and more common. We used a word cloud to describe the effects of regional anesthesia in pediatrics, and the most common word that came out is analgesia. It is also a component of balanced anesthesia as well as multimodal analgesia plans. It is an important technique to use for opioid-sparing and opioid-free anesthesia. It reduces stress hormones, and clearly these are all the benefits of using regional anesthesia. In recent times, a lot of importance has been given to neurodevelopmental effects of anesthesia in children, especially those under 3 years of age. A recent study that was the GAS trial, which compared the outcomes of general anesthesia versus regional anesthesia in children under 2 and the effects on neurodevelopmental outcome following anesthesia exposure showed that it was equivalent. So we can expect more studies like this coming out, studying the effects of general anesthesia and regional anesthesia in children, especially in infants, in the wake of more information that they are seeking in terms of neurodevelopmental effects of anesthesia. So coming to the safety data that exists currently for pediatric anesthesia, the French Society of Pediatric Anesthesiologists, they were one of the first to do audits and collect data on complications associated with regional anesthesia. The first one came out as early as 1996, and the second one came out in 2010. They sort of followed this up in a 5 to 10 year interval. And what these audits showed was that landmark technique was most commonly used at those times. The complication rate at that time still was as low as 0.12%. Peripheral nerve blocks and centroneuraxial blocks were done in equal measure in under 3 years of age, but as the children grew older, more peripheral nerve blocks were used. More recent studies are from the Apricot study, as well as from the PRAN, that's the Pediatric Regional Anesthesia Network, which came out in 2018 and 2019. The Apricot study was a European multi-institutional study, and they had over 4,000 children in that study that were recorded. They found that, again, centroneuraxial blocks, Caudal was the most commonly used. There were no long-lasting neurodeficits in any of these children or any serious complications. The PRAN network is a network of 27 hospitals in the United States who then feed data into this registry, and they recorded over 100,000 blocks. Their studies showed that the most common complication were related to catheter malfunction, block failure, infection, and vascular puncture. It also noted that the complication rates were higher with catheters versus single shots. There was no permanent neurological deficits reported. The risk of transient neurological deficit was at 2.4 in every 10,000 cases. There was a risk of last was at 0.76 to 10,000. And to put that to perspective, there were just 2 cases of severe last that were reported in over 100,000 cases with no fatalities. There was an incidence of cutaneous infection at 0.5% and 1 epidural abscess, and both of it related with catheter techniques. There was 1 epidural hematoma which occurred with a perivertebral catheter, interestingly. So what does all that safety data mean, or what do we gain from it? So this safety data is important because complications are very rare. It influences our clinical practice, and it indicates trends. For example, the earlier trends were that landmark technique was commonly used, but in recent times, regional anesthesia is performed using ultrasound or peripheral nerve stimulators. The data also informs future research. Audits often have limitations. These include ideas to plan future studies and what kind of data we need and what kind of data needs to be inputted into our various studies. It also addresses certain medical legal concerns. It also guides industrial labeling and approvals. Now that we've done with the safety data and we know that pediatric anesthesia and regional and pediatric anesthesia is safe, what are the challenges, or what is the differences between pediatric versus adult? Is there a difference? Yes. Do we need to know what they are? Yes. Why? Because that then informs our practice. I'd like to categorize these differences into 2 groups. One is the age-related challenges, and the other one, the challenges of the regional anesthesia itself. Pediatric anesthesia, or the pediatric age group, is challenging in the fact that they have such a wide age group. We have neonates, we have term infants, we have 2-year-olds, 8-year-olds, 16-year-olds who could actually qualify as the little adults. So their anatomy is different. The anatomy could be easier to identify, but also to keep in mind that the younger children that come in usually are sicker, could have syndromes, and hence the chances of detecting anomalies in this age group are quite high. Physiologically, they're still immature and at various stages of maturation, so the effects of regional anesthesia on their systems is varied. Pharmacology, again, they're at varying degrees of maturity, so the way they act to drugs and how the drugs act on the body are very different. Very often, the psychology and the understanding of a child is overlooked. For example, it's easy to explain to an adult that their hand's going to be numb and they're not going to be able to move it, but explaining that same thing to an 8-year-old might be challenging. Coming to the challenge of the regional anesthesia itself, we need equipment that is appropriately sized. For example, spinal needles for a neonate are different. Doing an epidural or placing a catheter in a child is again different. So the need for equipment is different. And of course, the ergonomics of arranging the machine and standing around a small child again adds to the challenges. So what does all of this mean? It means that we can't take an adult model and just have a face swap to fit a pediatric model. It requires more understanding and better delivery. The next part is on planning a block. What do we need to do before we perform a block? I would like to do this in 3 steps. The first is the science. The science of the block includes what kind of block are we planning? Is the block appropriate for that surgery? Are we looking for analgesia or anesthesia? And that would determine if we want a single shot or a catheter, what kind of drugs we can use, the dose of those drugs, and of course, the anatomy and the relevance of that block for that procedure. The second one is skill. We need to know how to do those blocks in pediatrics. For example, we might think doing a spinal technique in a neonate would be the most appropriate, but do we have the skill to do that block? And the third part is the protocol. So we can decide that the most appropriate block would be a catheter for that particular procedure. But if it is a daycare procedure, that catheter is useless. So what I'm trying to say is that planning a block in pediatrics is a team effort. It involves the surgeons, it involves the anesthesiologist in equal proportion, and the patient as well. We need to see how they fit into the protocol. So while planning a block, we need to see the science behind it, if we have the skill to do it, and if it fits into our hospital protocols. Moving on to some controversies and debates that exist in pediatric regional. The first question or the debate is, do we do it awake or asleep? In adults, it's recommended that we do it awake so that the patient can participate and warn us of any nerve injury. In children, the recent European Society and the American Society guidelines recommend that the performance of block be done under general anesthesia or deep sedation. The recommendation comes because placing a block in an awake or a moving child can be dangerous and difficult. What are the scenarios one would do it awake? Well, we could do it awake where general anesthesia we're keen to avoid it in case of sick neonates or preterm neonates, where they have a higher risk of apnea, hypoxemia, and bradycardia. And commonly, regional anesthesia techniques are then undertaken in surgeries like inguinal hernia repair, urogenital surgeries, which can be conveniently done under spinal or caudal in this age group. The second group of patients that we could do it awake in are cooperative children, typically in the 10 to 12 years of age, or even teenagers who are the actual adults. The second point of discussion is, should we do a neuraxial or a peripheral block? Again, with lots of recommendations and looking at audits, the trend is that peripheral nerve blocks are preferred over neuraxial blocks in children, mainly because landmarks are clear and constant. The dose of local anesthetic required is low, meaning to say that would then lead to a safer block. The duration of analgesia is longer, and the complications are 6 times lower. The complications in this regard are for single shots. The complications are slightly higher if you look at catheter-based techniques. The next debate is, do we use a test dose or not? This is debated because children generally have a high resting heart rate, so this could be a confounding factor in reading a test dose. And the second thing, these blocks are generally done under general anesthesia or deep sedation, which then again makes it difficult to interpret the response to a test dose. So test dose is usually given in children when they're awake, and possibly in the teenagers or the little adults again, where the test dose can be employed and interpreted well. The next thought is adjuvants. Adjuvants have been used to prolong the duration of analgesia and to improve the quality of the block. However, most of the data and most of the use that drives the usage of adjuvants is extrapolated from adult data, as ethical issues arise in doing pediatric studies. Most of the adjuvants that we use today are off-label uses. What's not studied is the developmental age and the potential for neurotoxicity in using these adjuvants. We haven't studied the role of preservatives that cause neurotoxicity again. However, they have found a positive role in facial plane blocks, and those are commonly used in these blocks to prolong the duration of analgesia. Just quickly pointing over a study where we did a network meta-analysis of adjuvants added to Caudal blocks to see which of those adjuvants actually were made a difference. So in the duration of analgesia, what came out first was neostigmine by increasing duration of analgesia by over 400 minutes, followed by tramadol and dexmedetomidine. However, overall, while looking at what actually reduced the doses of astamine or fin, we found dexmedetomidine to be the best. However, the study was limited because no safety data could be analyzed and no complications were reported. Some other thoughts: in plane versus out of plane. This comes down to safety and skill. In the hands of a skilled anesthesiologist, even out of plane can be safely employed. So it comes down to convenience, the skill, keeping safety in mind. The other is the use of nerve stimulators. It is again recommended to use the dual modalities. There are certain scenarios where dual modalities are better, especially in cases where anomalies are identified. And the last thought is on local anesthesia toxicity. Again, this is an issue as we tend to do these blocks under GA or deep sedation. So signs and symptoms of local anesthesia toxicity could be realized much later than in adults. A few words on regional anesthesia for chronic pain. In children, as in adults, regional anesthesia techniques can be employed for chronic pain. Commonly, sympathetic blocks and continuous nerve catheters are used for chronic regional pain syndrome, where we want to give them a pain holiday. We can do diagnostic and therapeutic blocks. They're commonly employed in conditions like chronic headaches, acute compartment syndrome at the abdomen, and other nerve entrapments. It can also be done for certain cancer and palliative care patients. It's commonly used for bone tumors. And joint pains are also a condition where regional anesthesia techniques are commonly used for chronic pain. This could be a whole talk in itself, and so but this talk would not be complete without a mention of spinal anesthesia in neonates. It is a team effort. It can be done successfully under skilled hands. It does require a lot of coordination between surgeons, the nurses, and the anesthesia team, and can lead to a successful, safe anesthetic for neonates. The other thing that I would like to put a thought to is block room requirements to accommodate a pediatric patient. Not many hospitals have numbers or a dedicated block room for pediatrics. And what's successful and what helps is to develop a pediatric block tray or cart with all the required equipment, especially since it could take time and coordination to gather all the equipment that's required for a pediatric block. So setting up a block tray or a block cart with everything on it labeled, like the examples shown, are important ways to improve the utility of pediatric blocks. So I would like to end my talk with these take-home messages, mainly that regional anesthesia in pediatric population is safe. We have over 2 decades of data pointing in that direction. We need to acknowledge the differences from adult practice, and that leads us to adopting a safe practice that's backed by science. Thank you for your patient listening.
Thank you very much to AORA, particularly to Prof. Balavenkat for inviting me to share my thoughts on caudal anesthesia for adult daycare surgery. Greetings, salam from Malaysia. Start the ball rolling. I have nothing to disclose with regards to this talk. This talk is mainly based on the article that we wrote, ultrasound-guided caudal epidural anesthesia for MRI targeted transperineal prostate biopsy. A group of us, anesthesiologists in my department, with Dr. Alan Sim, the urologist in my hospital, wrote this case series of our experience doing caudal epidural for MRI targeted transperineal biopsy as daycare. This is where we work. It is a multi-specialty hospital down south of Peninsular Malaysia, 140 odd beds. It is multi-specialty. Our urology service at the moment is still a single surgeon service. I'd just like to recap something about prostate cancer and the different biopsy or screening techniques. Prostate cancer is the second most common cancer for men, and if you look at the data that we have, Oceania leads the incidence at 79.1 per 100,000, followed by North America and Europe. Africa stands at 26.6 per 100,000 people, whereas Asia is the lowest, 11.5 per 100,000. It is unsure whether this is because of poor diagnosis or poor screening, or actually it is because of a true low incidence. There have been a recent, I would say, technique, which is transperineal biopsy. The current, I would say, the predominant technique has been so far transrectal prostate biopsy. In this current, in this systematic review, the authors concluded when looking at the data that transperineal and transrectal biopsies have the same diagnostic accuracy, but transperineal approach has a lower risk of fever or sepsis, if you like, and rectal bleeding. I'm just going to quote some of the statements in this few review article. The introduction of MRI and transrectal ultrasound fusion prostate biopsy has clear advantages over historical standard of care. And the MRI transrectal ultrasound fusion biopsy has demonstrated advantages in cancer detection when compared with just transrectal ultrasound guided biopsies. In this particular review article by the group in Australia, transrectal ultrasound guided prostate biopsy is most offered worldwide. Okay, but now transperineal biopsy, on the other hand, has been gaining popularity due to its superior sensitivity and lower rate of sepsis. And transperineal prostate biopsy is typically performed under GA with patient in lithotomy through the perineum. Cores of tissue are taken systematically with or without targeting under ultrasound guidance. Different techniques, for example, this MRI ultrasound fusion software and MRI in-bore. When we talk MRI in-bore, are actually technique tissue biopsy, prostate biopsies are, which is done in the MRI suite and in real-time MRI guidance. Can be used to target pre-identified lesions on MRI. The sampling can be done either by freehand or using a grid, as well as this robotic assisted prostate biopsy is also available in the market as an alternative. This group from China did a systematic review and looking at studies, MRI transrectal ultrasound fusion biopsies and transrectal ultrasound guided systematic biopsies, and they concluded that compared with systematic protocols, MRI transrectal biopsies detects more clinically significant and high risk prostate cancer cases and fewer clinically insignificant prostate cancer. When we talk about systematic protocols, it means that ultrasound is being used, but without any fusion of the MRI images to actually guide the operator. So it's based on the real-time ultrasound. So parts of the prostate gland is being divided systematically, and the samples are being taken from these different regions. So now we have this, which is actually a robot. What it does is actually it fuses the images from MRI as well as the real-time transrectal ultrasound images, and the robot guides, puts the needle guide at a place where the operator decides to sample the biopsies. What about anesthesia? We're just looking at what has been written in the literature. So this was a 2014 article by this Turkish group, and they applied, they had 3 groups of patients, one with periprostatic block, another intrarectal lignocaine, and the third was a pudendal block. This was for transrectal ultrasound guided prostate biopsies, and that they found out that in terms of pain and discomfort, they noticed that periprostatic block enables more comfort compared with the other 2 groups. This was a case series, and this describing the use of transperineal, so local anesthesia for transperineal prostate biopsy, and they had a total of about 1,287 patients, and they described that it is actually a feasible alternative for transperineal local anesthesia. Is feasible alternative for transperineal prostate biopsies. This was a study to compare local versus general anesthesia. So the pain was definitely higher in recovery for the GA group, but the median pain score for local infiltration was 5/10. This was a study to the patient outpatient transperineal prostate biopsy at the local anesthesia. So this was a case series. So they had about a total of 48 patients, and so during the actual procedures, pain scores were rated the highest during infiltration of local anesthetic with a median score of 5, and by the conclusion of the procedure, the median pain score was 1. So you can see that it's probably not a total anesthesia technique. They do feel quite a bit of pain during the actual local anesthetic administration, and some degree of pain at the end of the procedure. So this is what they did. Basically local infiltration using 25 gauge needle to anesthetize the perineum and subcutaneous tissue, and then eventually putting a 14 gauge cannula in the perineum at about midpoint of each prostate site, and anesthetize the periprostatic tissue using a 22 gauge 5-inch spinal needle, and they were using 1% lignocaine. There have been also documentations of caudal block for transrectal prostate biopsies. This particular Nigerian group, and this was a Chinese group, where they were looking at caudal block for over compared to periprostatic block and intrarectal local anesthesia for transrectal ultrasound guided prostate biopsy. So they had better anesthesia with the caudal block. So if you look at, this was the 2019 anesthesia guidelines for day surgery. So prostate biopsy was put as category B for pain medication post day surgery, and the B was actually mild, and they put paracetamol 1 gram 6 hourly as the discharge medication. So it's probably not too painful post-operatively, but intraoperatively, there can be quite significant pain and discomfort. Just quoting this definition by IJA, what we are doing for our prostate biopsies are actually real day care. The patients are discharged the same day in the afternoon. Okay, how do we actually do Caudal? Because when we were looking at the data, and the surgeon is suggesting to us to actually do Caudal for our patients. So we had to look up all this data, and just to recap how Caudal, particularly in adults, there is actually incomplete fusion of the lower portion of S4, S5, hence the sacral hiatus appearance. This sacral hiatus is covered by the sacrococcygeal ligament. There's a hiatus bounded laterally by the cornu, which is down here. The dura terminates as S2, and the sacral epidural space contains sacral and coccygeal roots, venous plexus, and filum terminale. The volume for the sacral canal is 8 mils, whereas the volume for Caudal is about 14.4 mils. Okay, just a recap on the dermatome. We would, for anesthesia, for transperineal biopsies, the area that we are looking to anesthetize is actually the lower sacral roots. And this is where we want it's actually S5, which is where we put the transrectal probe, and the needle goes through the S4 dermatomes. This is how we actually put the probe, and in most situations it will be a linear probe. Just to highlight the images, how we see these are, I'm quoting this from a review article, a caudal epidural block. So this is the transverse images and longitudinal images. So the sacrococcygeal membrane, the sacral hiatus, and the base of sacrum, and the needle goes through the sacrococcygeal membrane in the sacral space, the caudal space, and this is where the LA is being injected. Okay, we have kind of, initially when we tried to do this, we were doing it with the patient lying lateral, but I think in terms of ergonomics for both patients and operator, it's probably best to keep them in a prone position and position close to the edge of the bed with the dominant hand for needling and the ultrasound on the other side of the bed. This is the equipment that we used. We find the needle guide quite helpful, particularly because of the fact that slight different tilts can actually change the sonor anatomy of the caudal space. So by just using the needle guide, we can actually just bring the needle into the image that we are interested in keeping. This is how it is. On the left would be the caudate side, and the cath lab would be on the right, and the needle comes like that. And usually I would position it. This is actually myself doing so. My dominant hand, I'm right-handed, so my dominant hand is holding the needle. And this is how you see it. This is in the transverse view, and this is from the longitudinal view. These images are from the article. I'm just going to play this movie that so you can see the needle going through the sacrococcygeal and then the injection of the local anesthetic, and you can see this pump effect. So the pump effect gives you this confidence, and there's actually expansion of the space and collapse, an immediate collapse up there. So if you see this, it gives you the confidence that the block is going to work. Okay, but having done a few of this, sometimes this does not happen, particularly in the very elderly, where I say there's a lot more ossification going on around this region. So it may give you confidence in about 95% of the cases, but there are certain small group of patients who may not have this pump effect. This is what we use initially. We kind of progress from ropivacaine, and finally we are now using 1.5% lignocaine, 20 mils in our practice. There have been quite a dated case report for outpatient gynae procedures. This was published 2005 by this Taiwanese group. They used 20 mils of 1.5% lignocaine, and you can see that they documented that the duration of action of the anesthesia is about 46.66 minutes. So we find that probably a bit short from our experience. We probably feel that about 1 hour it can be still all right for the procedure, but anything more than an hour, then the patients will experience a bit of discomfort. And sometimes there's the need to actually perform general anesthesia or deep sedation. Okay, with regards to discharge criteria, one of the important things that our surgeon insists is that the patient be able to micturate spontaneously. So this is just quoting a paper, the Spanish group. This is a bit dated 2012. One of the important discharge criteria for ambulatory urology is actually spontaneous diuresis. And the issue is that usually with other techniques, particularly with intrathecal local anesthetics, even without opioids, fentanyl, for example, the patients end up with quite a significant delay of return of micturition. So this is a systematic review published in the Canadian Journal in 2012, and they were looking at data, and it could range from anything between 163 minutes up to 428 minutes. So the more drug molecules, drug mass that is being used, the longer the delay in return of micturition is going to be. Similarly, with epidural, we also, in this systematic review, there is a significant delay of return if bupivacaine is being used, whereas with shorter acting ones, for example, mepivacaine, then the return of incidence of retention is much less. But when lignocaine is being used, the shorter acting ones with and also chloroprocaine, you can see that the incidence of delay in micturition is actually quite low. So another point that I like to highlight is that sometimes, even though the sonor anatomy may be well visualized, but putting the needle through the sacrococcygeum can be difficult because of ossification. And ossification can be seen usually with the increased echogenicity, but sometimes it may appear as per normal, but the needle may not pierce the sacrococcygeum. So this is where we need to kind of move around and see where the needle can pierce, sort of to find the soft spot, so to speak. If I can conclude, this is the summary that the benefits of caudal epidural anesthesia with short-acting local anesthetics, i.e. lignocaine 1.5% for MRI-guided transperineal biopsy, include relaxation of anal sphincter. This is when the transrectal probe is being used. Minimal motor blockade of lower limbs, so the patient can actually move from the trolley up to the OT table and the other way around. At the end of the procedure, avoidance of hypotension, reduction in post-procedure urinary retention, so that most patients will regain their urinary function about 4 hours, and early discharge. Okay, just like to point out, we are now spinal prilocaine is now being marketed or available in Malaysia. We are now trying it. So this is something good, probably an alternative for our MRI daycare transperineal biopsy, and I think it's probably maybe a lot easier to perform because the endpoint of spinal anesthesia is where the CSF, and whereas the endpoint for an epidural caudal in adult can be a bit more tricky. So with that, I would like to thank you, and thank you again to Professor Balawenkat and AORA for the invitation. Thank you very much.
Dear colleagues, dear friends attending us on the other side of the net, good morning from my side. I am Eleni Moka. I am a consultant anesthetist from Greece, and I currently represent the European Society of Regional Anesthesia and Pain Therapy from the position of incoming president. My presentation will focus on diversity, equity, inclusivity, and how they can influence regional anesthesia practice. Before starting my talk, I would like to congratulate the organizing and scientific committee for this wonderful Congress, as well as to thank them for the honoring invitation. So, directly entering into the topic in the 20 minutes that are allocated to my presentation, I will try to first of all discuss the fundamental working definitions of the concepts of diversity, equity, and inclusion, and how these terms interrelate between each other. I will also explain you briefly on how inclusivity may influence regional anesthesia practice in terms of benefits, challenges, and barriers. And finally, I will focus on how regional anesthesia scientific societies can promote DEI and may contribute to optimal patients' care, advancing finally healthcare and health equity. So, moving on to the terminology regarding inclusivity into our practice and to the fundamental working definitions, in simple words, first of all, we need to understand some terms. Disparity is a significant adverse difference in health status or related outcomes between population groups and can become inequality when this adverse difference happens due to unequal access to resources or difference in distribution, and it can further become inequity when this unequal access to resources is fully unfair. It is true that disparity, inequality, inequity are terms that are interchangeable in daily practice and are often regarded as synonyms. It is true also that there is a transatlantic language divide. Why? Because in the United States, disparity is generally used for differences related to ethnicity or race, whereas in Europe, inequality is used in the context of socio-economic differences. It is important, though, that in the United States, the concept of disparity is now becoming closer to the definition of inequity. And in simple words, let's see what's the difference between equality and equity. Equality is when everyone has access to a particular resource, and this also applies to healthcare, to medicine, to anesthesia practice, whereas equity is when this access to the resource takes place in a way that it is right for them, for the people, and this is very important to understand this clear difference. In addition, diversity, equity, and inclusion are interconnecting and overlapping aspects. They are not the same thing. Diversity of people or perspectives is an outcome. It is different from equity, that is a process regarding freedom from bias or from favoritism and parity across differences, whereas again inclusion via power, voice, and culture is an outcome. And finally, inclusivity, that means providing equal access and opportunities and resources for people who might otherwise be excluded or marginalized, is clearly a practice and a strategy, if not a policy. And of course, the main question that comes to the table is how inclusivity and diversity can influence regional anesthesia practice. The answer is very simple, and in my opinion, comes from the title of this very successful, this clever article published in ASA Monitor back in February of 2023. According to the authors, inclusivity and diversity in healthcare is the pathway to building belonging, better care, and a healthier working environment. And if you wonder how this can happen, because the concept is quite complex, I really advise you to look into this special article on diversity and inclusion in our specialty published last year. According to the authors, inclusivity may offer advantages for both the provider and the institution, but mainly for the patients themselves. How this can happen? For example, when we have an expanded workforce diversity, we can have innovation, creativity, increased engagement from the provider, the ability to solve complex problems, increased efficacy, wellness, job satisfaction, reduced percentages of burnout, increased productivity, reduced absenteeism, talent optimization, financial stability, and profitability for the institution. In other words, we can reach excellence, a situation where every provider has the opportunity to attain their full potential. And as a result, we can have patient advantages like improved access to quality care, reduced health disparities and care inequalities, and improved outcomes, meaning offering safe and equal treatment opportunities to every patient, reaching finally the health care, but most importantly, the health equity. And it is true that in our specialty, the ideal scenario should look like what we see in the slide, not only to have equity, but to move further to the concept of belonging. However, the reality is fully different in our practice and much more disappointing. Why? Because we have data about healthcare inequalities in relation to the regional anesthesia provision. In the United States, clearly racial, ethnic, gender, and insurance disparities have been identified in the provision of regional anesthesia in orthopedic surgery. It is very disappointing to see that minority patients may be more than twice as likely to receive a general anesthetic versus white patients in total hip and total knee arthroplasty. In addition, only 6% and 16% of Black patients have the chance for peripheral and central nerve blocks, respectively, for hip fracture surgery. Female patients are 11% less likely to receive regional anesthesia versus male ones, whereas patients with Medicaid insurance are almost 40% less likely to receive regional anesthesia techniques versus those with a private insurance. The same disappointing conclusions are coming from the obstetric anesthesia cohorts in relationship to the regional anesthesia rates and its application. Why? Because Black and Hispanic women are more likely to receive a general anesthetic for cesarean section. But also we can have racial disparities in pain management across disciplines, with Black patients consuming far lower mean annual opioid dose versus white patients. And one would wonder if these data are similar in the European continent. It is true that we do not have data from Europe because we do not have the large databases and the large registries that exist in the US. In addition, applicability of the US data is not possible due to different ethnic demographics in the European Union. It is true that the healthcare system between United States and Europe is fully different. In the US, it is privately operated with access by insurance and with 14% of the population being uninsured, where access to care in Europe is independent of the ability to pay and is delivered via the NHS. However, even in Europe, we can see some publications that show us that probably disparities in the provision of regional anesthesia exist. For example, we have this article published in 2023 by the group of Nuala Lucas, based on the records of more than 6 million births from the National Healthcare System database in an effort to investigate the association between ethnicity and the provision of care in obstetric anesthesia in a 10-year period. And it seems that disparities indeed exist, at least in the obstetric anesthesia care. Why? Because in the case of elective cesarean section, general anesthesia can be 58 and 35% more common in Black Caribbean and Black African women, respectively, versus white women. In emergency cesarean section, a general anesthetic is 10% more common in Black Caribbean versus white women, whereas in labor, Bangladeshi, Pakistani, and Caribbean parturients are 24, 15, and 8% less likely versus the white women to receive a central neuraxial block. And because in Europe we have circulation of population with the immigrants arriving in the European Union, there are publications comparing the provision and the appropriateness of healthcare between immigrants and non-immigrants originating from Germany. And according to the authors, involving more than 6,000 patients, it seems there is an under-provision of care in women, mainly in first-generation immigrants, in those with reduced language proficiency and reduced educational attainment. And when the healthcare providers were asked about the reasons for this fact to happen, the top reasons for a lower rate of epidural anesthesia in the obstetric population was the fear on the part of the immigrant women in 64% about the technique and in 50% the language barrier. It seems also that we have the disparities not only in the provision of care, but in the workforce environment. And unfortunately, the current status in both the United States and Europe is quite disappointing. We can see the demographic composition of anesthesiology in the academic environment and in the resident cohort, and we notice that women represent only around 30% of these cohorts. And more disappointingly, Black and Hispanic population are around the 5% of the academic faculty cohort and the anesthesiology resident cohort as well. In addition, less than 6% of full professors in all specialties are from underrepresented groups. Women make up at maximum 7% of full professors and 14% of department chairs, and we notice a very low percentage of women as board examiners. So we have a problem, and when we have a problem, we are obliged to identify the etiology, and the etiology of the disparities that have already been presented has to do with the patient, the provider, the systems, and the policy. In the case of patient, it is important to remember that we have different norms and standards, lack of quality information or misinformation, language barriers, social influences, and a reduced health literacy level. In the case of the provider, important reasons are the bias, implicit or in-group stereotypes, the microaggressions, the cultural competence, and the lack of availability of workforce disparities. Whereas in the case of systems and policy, we identify as reasons the service availability and accessibility, the system bias, the lack of cultural support, and again, the language barrier. So when we have the etiology, we need to find the solution. And it is true that achieving greater health equity should be an opportunity for our specialty. And when I say opportunity for the case of regional anesthesia, I mean regional anesthesia provision everywhere. But in order to achieve this, We need not only a vision, we need a clear strategy and a concise plan based on a multi-level interdependent framework as it is presented in the slide. This relies on an iterative cycle starting from the patient and then moving to the clinician, to the group, the department, the healthcare organization, but also to the scientific associations and to the specialty societies in an effort to identify the health and healthcare disparities, to focus on social determinants of health, achieving finally healthcare and health equity via various steps like optimization of care, application of regional anesthesia and ERAS programs, documentation of improvement in healthcare access and health outcomes, and of course, by having a cultural competency and a group diversity. It is beyond the scope of my talk to analyze you all the steps that have been presented via the iterative cycle. I would like more to focus on the role of the regional anesthesia scientific societies in achieving healthcare and health equity, because I believe they could serve as key drivers. And what they can do. First of all, before doing anything, we need to understand that diversity does not automatically lead to inclusivity. We need a pathway, an organizational evolution away from disparity and towards equity. And this includes various steps like securing leadership buy-in, identifying common goals, and developing a common policy, a common strategy and plan, applying an oversight structure to make the policy visible, collecting and reporting data to monitor our performance, and most importantly, engaging dialogue to develop interventions that could mitigate the disparities if we want to respond to resistance and take the pledge. And in this concept, the European Society of Regional Anesthesia has welcomed an article by the blog These Girl Blogs in its newsletter, whereas the author discusses on how to narrow the gender gap and to support women in the field of regional anesthesia. The Royal College of Anaesthetists has created a committee on equality, diversity, and inclusion. The same applies to ASRA, focusing on the role of women in regional anesthesia and pain medicine, but also to the Society of Obstetric Anesthesia and Perinatology, because they created not only a committee, but published also a diversity and inclusivity statement. And in this context, the most important when we discuss about RA societies is the possible partnership initiatives. We need to establish joint DI committees, scientific interest groups, and create joint task force on inclusivity to ensure that membership, leadership, and programming reflect the diversity, to provide the resources and guidance to members and leaders as far as implicit bias and microaggression, and most importantly, to develop and release common guidelines and position statements that could serve as a standard for best practices in the field of DEI. In addition, the societies, by partnering between each other, they can organize combined education and networking opportunities to foster cultural competency and diversity training to providers in an effort to understand the social determinants of health in the perioperative setting, to enhance the culture of belonging and to reduce stereotyping and bias, to promote health policy education in order to effectively advocate for patients, and of course to implement patient education programs to increase the knowledge of patients on best practices for accessing regional anesthesia care, for a knowledgeable participation in treatment decision. And it is also important to translate informative material in various languages so that we can enhance the health literacy level in every patient population. Finally, it is extremely crucial when partnerships are created between regional anesthesia sister societies to organize common advocacy for policy changes by raising at the beginning the awareness, by promoting the diversity, and by encouraging the healthcare institutions to recruit and retain providers from diverse backgrounds and to offer training for all, then by creating supporting working environment to provide resources about work-life balance, workplace discrimination, harassment, and finally by engaging and collaborating patients groups to gain insights of their needs and perspectives. If we finally want to advocate and have an advocacy, a policy advocacy with guidelines on language access, on patients with disabilities, and on cultural competency. To conclude, as a summary, as a take-home message, I would say the title of this excellent editorial of Paloma Toledo, published in 2022, according to which we can expand our horizons and as anesthesiologists, we can improve health equity. In order to achieve it, we must think of our practice at the population level. We need to make partnership between scientific societies because by this way we can contribute to health equity and universal health coverage. But in order to achieve it, we need a framework and a clear strategy. The society leaders must make efforts to remove barriers, but they need to remember that it takes perseverance, commitment, and multiple recruitment cycles. All in all, the most important conclusion, in my opinion, is that equity in our subspecialty, in regional anesthesia, but also in anesthesiology, needs to be embraced from the top if we want to be very successful. And at this point, I would like to stop and thank you for your attention, but also to invite you to the World Congress of Regional Anesthesia and Pain Medicine that takes place in Paris in September, where many topics regarding disparities, diversity, and inclusivity will be discussed. Thank you very much for your attention.